Thank you everyone for joining us for the first session on disorders of the liver. Our panelists today are Dr. Tara Ghaziani, who is a clinical assistant professor of medicine here at Stanford. Her research interests focus on hepatobiliary malignancies, and she's the clinical director of the liver cancer program here at Stanford. We also have Dr. Ray Kim. Dr. Ray Kim is a professor of medicine and is division chief for the Department of Gastroenterology and Hepatology here at Stanford. His research expertise is in epidemiology and prediction modeling in chronic liver diseases. We also have Dr. Radhika Kumari, who is a clinical associate professor of medicine here at Stanford. She helps to direct our clinical outreach program, and her research interests are in portal hypertension-related complications. She is also the immediate past president of the Northern California Society for Clinical Gastroenterology. We have Dr. Mindy Nguyen, who is professor of medicine and director of the Transplant Hepatology Fellowship here at Stanford. And Dr. Nguyen has done extensive work in epidemiology, clinical outcomes, and therapeutic clinical trials for viral hepatitis, non-alcoholic fatty liver disease, and liver malignancies. And finally, we have Dr. Robert Wong, who is an associate professor of medicine here at Stanford and at the VA in Palo Alto. His research career has focused on clinical, epidemiologic, and outcomes research in viral hepatitis, NASH, and transplant outcomes. So thank you for all our panelists for joining us today. I will be moderating today's session. Again, my name is Deepti Dronam-Raju. I'm one of the transplant hepatologists, and we will start without further ado with our first question. Okay, so we start with a 55-year-old woman with long-standing history of elevated liver enzymes with an ALT of 57 and an AST of 46. An extensive serologic workup has been done and has been negative. Imaging was notable for an echogenic and enlarged liver with patent hepatic and portal veins. The patient does not have a history of any alcohol excess. Over the course of the evaluation, you've ordered a liver biopsy that reveals histologic features that are typical of non-alcoholic steatohepatitis with stage 1 fibrosis. The patient now presents for her biopsy results. She wants to know what treatments are available for her NASH. Which of the following statements is true regarding the management of non-alcoholic steatohepatitis? Our answer choices are A, vitamin E has not been demonstrated to improve fibrosis in NASH. B, metformin improves inflammation and ballooning in NASH. C, ursodeoxycholic acid improves steatosis and inflammation in NASH. Or D, iron depletion through phlebotomy improves inflammation and fibrosis in NASH. So we'll go back to our question stem so we can see the question again. And again, the answer choices here are going to be A, vitamin E has not been demonstrated to improve fibrosis. B, metformin improves inflammation and ballooning. C, ursodeoxycholic acid improves steatosis and inflammation. Or D, iron depletion through phlebotomy improves inflammation and fibrosis. Give everyone a few seconds to answer that. Okay, let's go see how people have answered. Okay, it looks like most people have chosen vitamin E has not been demonstrated to improve fibrosis in NASH, with a few people choosing metformin improving inflammation and ballooning in NASH. And so we'll turn to Dr. Robert Wong to help us go through the answers for this question.
Great. Hi, everyone. Thank you. So going back to the question stem, so it's a relatively long question, but really it's a lot of information that doesn't necessarily, you don't really need that information to answer the question. Really, the question is asking you, what do you know about treatment of NASH? And all the question stem is really trying to paint a picture of a typical NASH patient, but really it tells you already that the biopsy shows NASH with stage 1 fibrosis. So let's go to the questions again. So that's great. Answer A is correct. We'll go through the other answers first to sort of explain why those answers are not correct. So starting from the bottom, no one selected D, which is great. Iron depletion through phlebotomy, that's really trying to get you to think about treatment of hemochromatosis. There's no role for iron depletion therapy in NASH, no evidence supporting that as a therapeutic method. Going to answer C, also no one selected that, so great. URSO has been studied in some small studies for NASH, but really hasn't panned out into improving any of the clinical biomarkers or histology. URSO really, as many of you know, is used for treatment of PBC. Answer B, so some of you selected answer B, and sort of clinically, you know, I sort of understand why some people might select that, because you think NASH patients, they likely have insulin-resistant diabetes. So if metformin, you know, is an agent that is used for treatment of diabetes, interestingly, there has been several studies with inconsistent data, and so far, none of the metformin studies looking specifically in treatment of NASH has shown to improve histologic findings of inflammation and ballooning. So that leads us to vitamin E, and this really tries to get you to remember the PIVEN study that looked at pioglitazone versus vitamin E for the treatment of non-diabetic patients with NASH. And in that study, vitamin E did show a statistically significant improvements in histologic features of steatosis and steatohepatitis, but getting to this question, it did not show improvement in fibrosis. And so that's why answer A is correct. It did show improvement in histologic findings of steatohepatitis, but did not improve fibrosis.
Great. So in this patient, what would you advise her then?
Yeah, great question. So, you know, unfortunately, as many of you know now for NASH, there's a lot of exciting things right on the horizon, but we don't really have FDA-approved therapy specifically for NASH. And in my clinic, in the approach of NASH and NAFLD patients, it really focuses on sort of modifiable factors, such as improving their metabolic disease components, optimizing management of diabetes, insulin resistance, hypertension, their dyslipidemia or hyperlipidemia. We also try, you know, at the VA, there's a very nice weight loss program, but many programs have similar types of, you know, nutrition and counseling programs. But weight loss studies have shown 5 to ideally 10% body weight loss has shown improvements in histologic features. So we really try to, you know, it's easier said than done, but we try to encourage patients, diet, nutrition, weight loss, optimizing metabolic disease risk factors. And if you have access to trials like at Stanford and surrounding institutions, trying to see if any of your patients are eligible for enrollment in clinical trials.
Great. Thank you so much. We'll move on to the next question. Okay. Here we have a 27-year-old man with a history of bipolar disorder who presents to the emergency department with confusion and jaundice. His vital signs are as follows. Pulse is 100 beats per minute and regular. He has a blood pressure of 125/70. Respiratory rate is 14. Oxygen saturation is 98% on room air. His exam is remarkable for jaundice and moderate right upper quadrant tenderness on palpation. His labs show a CBC with a white count of 9.1, hemoglobin of 8.5, MCV of 99, platelets of 120,000, and his LFTs show an AST of 1250, ALT of 1555, alkaline phosphatase of 53, total bilirubin of 4.1, albumin of 3.9, and an INR of 1.7. The right upper quadrant ultrasound shows a normal gallbladder with no gallstones. The CBD is 3 millimeters. The liver is normal in size and contour, and there are no liver masses. The Doppler study shows that there's normal flow in the hepatic and portal veins. The reticulocyte count is 24%. The haptoglobin is less than 6, and LDH is significantly elevated. The peripheral smear shows no schistocytes, but macrocytes and nucleated RBCs. This clinical scenario is most compatible with which of the following diagnoses? Acute Hep B, ischemic hepatitis, Wilson's disease, autoimmune hepatitis, or Budd-Chiari syndrome. And again, we can go back to that question stem and take a look at the question one more time as we're going through the answers. So does this process most resemble acute Hep B, ischemic hepatitis, Wilson's disease, autoimmune hepatitis, or Budd-Chiari syndrome? Okay, and take a look at the answers. Okay, the vast majority chose Wilson's disease, and then we have a few that have chosen acute hepatitis B. And I'm going to turn to Dr. Kumari to answer this question.
Hi, guys. Good morning. So, Deepti, can we go back to the question, actually?
Yep.
So, board tests, Wilson's disease is the right answer. So, board tests, hereditary questions, the percentage is about 2 to 4%. So, it is important to know the pattern of inheritance, and there are some salient features for every hereditary condition. So, and also Wilson's disease is a diagnosis of exclusion. So, where the first and foremost thing in this question is the young guy who's presenting with some degree of psychiatric disorder. So that should raise a red flag in itself. His blood pressure is fine, so definitely we are ruling out ischemic hepatitis. Then comes, he's a male, so most likely is not autoimmune hepatitis, and his ultrasound is normal too, which rules out Budd-Chiari syndrome. So basically it's a diagnosis of exclusion, and the patient also has Coombs negative autoimmune hemolytic anemia. The other thing that points us to diagnosis is the bilirubin alkaline phosphatase ratio here, which is less than 2. The alkaline phosphatase level is low at 53, and the ratio is less than 2, so that also helps with the diagnosis. So for Wilson's disease, so the 3 salient features in terms of board, when the board test is diagnosis, patterns of inheritance, and extrahepatic manifestations, and some factors which can be reversible and irreversible. So these are some salient features that will be tested. Any other questions that I can answer?
Yeah, I think we have your slide to if you just wanted to go over your take-home points from your presentation on Wilson's disease, that would be great.
So as I mentioned, they do check the pattern of inheritance. So Wilson's disease is an autosomal recessive condition, which affects the locus is on chromosome 13. And the gene that's affected is the ATP7B. We do not need to test for ATP7B if we do have salient features for diagnosis. If the patient's ceruloplasmin is less than 20, urinary copper is more than 100, and on slit lamp you do have KF rings, then we do not need to check for ATP7B. The only time we do go to check for ATP7B is when we only have one of the things that I just mentioned, and we do want to confirm, and also the liver biopsy does not have enough copper quantitative index. The copper quantitative index in liver biopsy should be more than 250. If it is between 50 to 250 and have only one of the salient features that I just explained, then we do check for ATP7B. And in Wilson's disease, the salient feature is there is decreased secretion of copper into canaliculi, leading to excess deposition of copper, not only in the liver, in the basal ganglia, which leads to the psychiatric and also dysarthrias, and they are irreversible. So early diagnosis is important. Deposition of copper in other organs leading to the particular manifestations pertaining to that organ. So it's not only limited to the liver, and they can present with acute presentation with liver failure, or they can present with asymptomatic, being tested for other conditions. If patients present with acute liver failure, the only treatment that helps is the liver transplant. And liver transplant carries a great prognosis when done for acute liver failure for Wilson's disease. But again, it is a diagnosis of exclusion. And chelation is done for maintenance treatment if patient is presenting as a chronically elevated LFTs. In order to decrease end organ damage is very important. And again, the dysarthrias, the basal ganglia deposition is irreversible. So chelation should be started as early as possible. And copper and ceruloplasmin levels at various stages. So once chelation is started, the level of copper in the urine should be between 200 to 500 micrograms per ml. So, and trientine is preferred over to penicillamine because penicillamine has a lot of skin reactions. It can also worsen neurological symptoms. So trientine is preferred. So these are the salient features, and these are the most important points that board will test you on Wilson's disease. Any questions?
Great. Thank you so much for that comprehensive review of Wilson's disease. We appreciate it. And I think, like Dr. Kumari said, and we appreciate her coming, she's on service right now, that there's pattern recognition here. So you have a young man with, they said bipolar disorder, he's got a hemolytic anemia and a low alkaline phosphatase. So they kind of give you those salient points in the question that should really push you toward the diagnosis of Wilson's disease. Okay, do any of the other panelists have anything else to add on that? I think it was a pretty comprehensive answer. Any questions from any of the attendees? Okay, we will move on to the next question then. So the next question is a 57-year-old man with a history of alcohol abuse who presents to the emergency department with the complaint of right upper quadrant pain, feverish chills, and jaundice for 5 days. He reports no dysphagia or odynophagia, no diarrhea or constipation, and his vital signs are as follows. His pulse is 92 and regular, blood pressure is 145/70, respiratory rate is 14, oxygen saturation is 98% on room air, and his exam is remarkable for a moderately tender hepatomegaly. His labs show a white count of 16,000, hemoglobin of 12.1, platelets of 147,000, and LFTs show an AST of 143, ALT of 88, alkaline phosphatase of 110, total bili of 11.2, albumin of 3.0, and an INR of 1.6. The right upper quadrant ultrasound that you perform shows a normal gallbladder without gallstones, no pericholecystic fluid or gallbladder wall thickening. The CBD is normal at 3 millimeters, but the liver is enlarged, and there are no liver masses seen. And the Doppler ultrasound shows normal flow within the hepatic and portal veins. The spleen is mildly enlarged. Okay. In this patient, a liver biopsy would most likely show which of the following? A, PAS positive diastase resistant globules in the hepatocytes. B, ballooning degeneration and Mallory's-Hyland. C, lymphoplasmacytic infiltration with rosettes. D, extensive fibrosis with minimal inflammation, or E, granulomatous inflammation. And go back to the question one more time. And again, the answers are A, PAS positive diastase resistant globules in the hepatocytes. B, ballooning degeneration and Mallory-Hyland. C, lymphoplasmacytic infiltration with rosettes. D, extensive fibrosis with minimal inflammation, or E, granulomatous inflammation. Okay, we'll go to the answers. I think everybody here chose B, ballooning degeneration and Mallory's-Hyland. And I'll go to Dr. Wong again to tell us why this is the right answer.
Yeah, perfect. So congratulations, everyone. That's exactly right. But let's go back to the questions then so we can just sort of deconstruct it a little bit to kind of, rationalize what we're thinking. So as you go through the questions then, I'm sure all of you immediately identify that this is a patient that's presenting with acute alcoholic hepatitis. The presentation makes sense. And as you look through, there's a lot of detail here which, you know, at least for this question may not be needed because really they're asking you what are histologic findings. But I think it's still key to sort of go through this and understand what they're trying to communicate to you. And as a teaser, some of this information may come up in a subsequent question later in this session. But looking through his labs, you see that platelet count is 147,000. And so, it's below the 150 threshold we typically think of. But in someone that's actively drinking, you would expect it to be even lower. So the fact that it's 147 maybe suggests that there's not it's not extensive cirrhosis, for example. Can't say that for sure, but just little clues that you can look at. For trainees that may be on listening, the AST-ALT ratio we think of, characteristic, AST higher than ALT for alcoholic hepatitis. And then here is what is important, looking at the bilirubin 11.2, and then PT-INR elevated, INR 1.6. Why is that important? Well, there's a lot of different ways we think and stage severity of alcoholic hepatitis. One common way is using the Maddrey's score or discriminant function. And I don't remember on boards if they give you that formula, but you don't really need it. I mean, you just look at how elevated the bilirubin is and how elevated the PT-INR is, and you can sort of estimate that this person probably has, a relatively high discriminant function. Not important for this question, but will be important for a subsequent question to think, how to manage someone with a high discriminant function, acute alcoholic hepatitis. And then some of these other details that they give you, just want to help you realize that there's nothing else going on. There's no portal vein fibrosis. There is some degree of portal hypertension with the spleen enlarged, but not that important because really it's the histologic findings. So next, back to the answers, please. So everyone identified that B is the correct answer, but let's just look at why the other answers are incorrect. Answer A, PAS positive diastase resistant globules. What that, keywords to remember, word association. So you think this is trying to point you to alpha-1 antitrypsin, and you see that in biopsies associated with that. Answer C, lymphoplasmacytic infiltration with rosettes. Again, some of the keywords there should trigger in your mind, autoimmune hepatitis. So even if you don't know the correct answer is B, you can sort of process of elimination get to the right answer by eliminating why the other answers are wrong. Answer D, extensive fibrosis with minimal inflammation. So this one can be tricky, and that's why I was sort of emphasizing the platelets sort of being borderline, because the fact that it's borderline sort of suggests that this is not someone with really severe or advanced cirrhosis. And AST-ALT elevated, not super high, but the fact that it is elevated does show that there is some hepatitis or inflammation. So it makes answer D tricky, but a little bit less likely as well. And then answer D, granulomatous inflammation, is sort of non-specific. You can see it in a variety of chronic infectious states, also sarcoid, things like that. But based on the clinical presentation of alcoholic hepatitis, you can sort of rule that out. And so that brings you, by process of elimination, even if you did not know it, the answer B with balloon degeneration and Mallory's hyaline, or also called Mallory-Dank bodies, are what is usually seen in alcoholic liver disease. Not specific. You can sometimes see this in NASH as well. And so that's why getting a good clinical history of alcohol use is so important in sort of distinguishing ASH, or alcoholic liver disease, versus non-alcoholic steatohepatitis. But answer B is correct.
Thanks so much, Dr. Wong. And for you and the other panelists, in this patient, would you perform a biopsy in a clinical setting?
Yeah, I'll say what I think, and then other people can add on. We generally do not perform liver biopsy, especially if the clinical presentation is so clear. Definitely not for staging disease. The only time where I would think about performing a liver biopsy as more for diagnostic purposes, where if there's a potential competing diagnosis that cannot be ruled out, perhaps, there may be an autoimmune picture that's going on, or the biopsies show, or sorry, the serologies show some other things that suggest a concurrent disease, and it may change management, then I think there can be a role for a diagnostic liver biopsy. But for the typical acute alcoholic hepatitis, I generally, from a clinical practice standpoint, don't use liver biopsy. I don't know what other people think.
Everybody's nodding their heads. Agree. Yeah, I agree. I think, in a normal clinical setting, you may not always have the biopsy. It is typically a clinical diagnosis. And I think this is one of the slides from one of our presenters' slide decks, where you can see if the patient presents with the classic symptoms of fever, right upper quadrant pain, jaundice, and leukocytosis, and you've ruled out infection with the right history of alcohol use, that you might lean towards this diagnosis. Again, as Dr. Wong mentioned, the hyperbilirubinemia, the AST, ALT ratio, and that history of alcohol use. And there's the histologic findings associated with alcoholic hepatitis.
Yeah, and one thing that they didn't mention on the question stem, and you can see here on the slide, is you get macrovesicular steatosis. You see those kind of white globules, also non-specific, but that's another feature you can see in alcoholic hepatitis.
Great. Are there any questions from any of the attendees so far? Just feel free to use the Q&A feature so that we can answer them for you as we go along. And if there's no other questions, then we can go to the next question. Okay. So here we have a 49-year-old man with an 8-year history of COPD who's found to have the following liver enzymes: AST92, ALT105, alkaline phosphatase 105, total bilirubin 0.9, albumin 3.0, INR 1.2. The CBC is remarkable only for platelets of 99,000. A right upper quadrant ultrasound is performed and shows a normal gallbladder with no gallstones, and the CBD is 3 millimeters. The liver is noted to be small in size with a nodular contour, and there's no liver masses seen. The Doppler portion of the study shows normal flow within the hepatic and portal veins. There is moderate splenomegaly that's noted. The hepatitis serologies, the ANA, the anti-smooth muscle antibodies, iron studies, and serum ceruloplasmin are all negative. So which of the following tests would you order next for this patient? A, urinary copper excretion. B, C282Y mutation analysis. C, anti-liver kidney microsomal antibody. D, alpha-1 antitrypsin phenotyping. Or E, liver biopsy. So we can go back to that question stem. And again, take a look at the labs that you're given and the imaging that you're told about. And is the answer here A, urinary copper excretion, B, C282Y mutation analysis, C, anti-liver kidney microsomal antibody, D, alpha-1 antitrypsin phenotyping, or E, would you do a liver biopsy? Okay, we can go to the answers here and see how people have responded. Okay, everybody chose D, alpha-1 antitrypsin phenotyping. And we'll turn to Dr. Ghaziani to tell us why this is the correct answer.
Hi, everyone. Hope you're enjoying the course so far. I'm glad we're changing the gears from NASH questions to some other type of liver disease. So if we go back to the question stem, that would be great, Deepti. So in this question, if you just quickly look at the presentation of the case, as you see, everything is suggesting that we're dealing with a patient with chronic liver disease with mildly abnormal ALT, AST, up to 2-3 times normal. Alkaline phosphatase is pretty normal. Bilirubin is normal, but the albumin is slightly low. And also platelet count is low. as well as the abnormal findings on the ultrasound, all suggesting of like chronic liver disease or cirrhosis with nodular liver, splenomegaly. So I think the question is trying to tell us that how we actually approach to these patients in terms of finding the etiology. And I like the way that the question is presented, that tells you what we actually do at the initial step, what tests we do for the initial approach, which includes the hepatitis serologies, the autoimmune markers, including antinuclear antibody, anti-smooth muscle antibody. And if this was a female patient, it would also need a AMA or antimitochondrial antibody. We do the iron studies, including transferrin saturation, ferritin level, and also a serum ceruloplasmin level. And then now I think the question is that what is while we are having all the negative results, what's the next step? If we go through the answer is alpha-1 antitrypsin phenotyping, but why the other answers are not correct. Dr. Kumari went through the diagnosis of Wilson's disease, quite comprehensively today. If we have suspicion for Wilson's disease, if the patient is young with some history of either psychological or neurological disorder, your alkaline phosphatase is on the lower side, and the ceruloplasmin is low, then obviously you go to the next step to diagnose the Wilson's disease with urinary copper measurement or serum copper, and also the eye exam. Just one point about ceruloplasmin, that in patients who present with acute or fulminant Wilson's disease, 15% of them actually can have a normal level of ceruloplasmin as an acute phase reactant, so that wouldn't rule out. And the other clues in terms of having suspicion for Wilson's disease, as Dr. Kumari said, is hemolytic anemia and very high bilirubin level, but usually you see those in the acute setting, like a patient with liver failure or fulminant hepatitis. C282 mutation analysis refers to evaluation for hereditary hemochromatosis. This patient apparently has normal iron indices. So if the ferritin is elevated or your transferrin saturation is above 40% in women or 50% in men, obviously you want to go to the next step and doing the mutation analysis. Is a DNA mutation analysis, and C282 is the major mutation, and there are other two minor ones. So that would be your next step. Anti-liver kidney macrosomal antibody also refers to evaluation of autoimmune type of liver disease, and this antibody is rarely positive, and it's really not in our usually it's not in our first step evaluation. This patient is a male, again, with normal anti-smooth muscle and ANA, so our suspicion is pretty low for autoimmune liver disease, so probably we're not going to test for this antibody. So now, why alpha-1 antitrypsin phenotyping? I don't think anybody wants to know too much detail about the pathogenesis of this disease, but just summarize it, that alpha-1 antitrypsin is an enzyme, a protein that is made by the hepatocyte, and the deficiency of this enzyme, you'll see unfolded abnormal protein that is kind of accumulated in the hepatocyte. Therefore, the level of antitrypsin in the serum is going to be low. And because this is an enzyme that is protective in lungs in terms of protecting against elastase in the lungs, in terms of deficiency, you will see patients present with kind of obstructive type of lung disease. The key in this case is that COPD is in the history. So we look at the demographic of the patient and history, and other than the labs and radiographic features. So this is a male with COPD in an age less than 50. So it will be it will raise some question about potential lung disease with related to alpha-1 antitrypsin. In terms of the evaluation, so the main thing is to do the phenotyping, which is done by this measurement of protein, different type of protein of alpha-1 antitrypsin. The M type is a normal one, and the Z and S are the abnormal one. We don't do the genotyping. The first step, obviously, for confirmation of diagnosis, then we do the genotyping. And the ZZ phenotype is the one that has the most severe type of alpha-1 antitrypsin deficiency, say with liver disease and lung disease. But however, the heterozygous form of this alpha-1 antitrypsin deficiency in conjunction with other type of liver disease, if there is another type of liver disease, also can lead to chronic liver disease and decompensation. I think the liver biopsy, do we do the liver biopsy? Obviously, for diagnosis of alpha-1 antitrypsin, we don't really need to do the biopsy. And with the phenotyping and further genotyping, we can make the diagnosis. However, if we do that, then the PAS staining is done. And basically this abnormal protein in alpha-1 antitrypsin deficiency, they're resistant to the digestion, and that's why we see those globules on the biopsy. I think liver biopsy, as Dr. Wang suggested in other case, is done if you think about concomitant other type of liver disease. You have minimally abnormal other like autoimmune markers or any other question about other type of liver disease, you may do that. I think, if any other questions, I'm happy to answer.
No, thank you so much. I think that was really comprehensive.
Can I ask a quick question? So this patient had COPD, and how important is that in this picture? So if this patient did not have COPD, is this still the right answer?
You can go back
All
to
right. Yeah, I mean, COPD also, usually seen in the severe form of alpha-1 antitrypsin, like the ZZ form, but the age is important. So it just raises the suspicion, I guess. Younger patients with COPD without history of smoking, I guess, then you might think about a clue toward what the etiology of liver disease, but the absence of COPD is not going to rule out alpha-1 antitrypsin deficiency. I don't know if Ray, you have other.
I mean, that was the point that I think is worth making, that you don't necessarily have to have full-blown alpha-1 antitrypsin clinical picture with COPD and everything for us to suspect that being an underlying etiology of liver disease.
Correct.
Great, thank you. And go to our next question. Okay. Here we have a 34-year-old African-American woman who presents to you for evaluation of persistently elevated liver enzymes. Her alkaline phosphatase is 256, AST is 42, ALT is 24. Her total bilirubin is normal. She has no other medical diagnoses. She does not drink any alcohol or smoke tobacco and complains only of fatigue and a dry cough. Her serologic testing for viral hepatitis, autoimmune liver disease, iron overload, and alpha-1 antitrypsin deficiency is negative. Her abdominal ultrasound reveals an enlarged and heterogeneous appearing liver with patent hepatic and portal veins, and the chest X-ray reveals bilateral hilar adenopathy. You recommend a liver biopsy, which reveals multiple small granulomas. Her serum angiotensin converting enzyme level is elevated to 165, with the upper limit of normal being 53. Which of the following statements is true regarding hepatic sarcoidosis? A, it's a diagnosis, hepatic sarcoid diagnosis mandates initiation of corticosteroids. B, hepatic sarcoid is characterized by caseating granulomas within the liver. C, an elevated serum angiotensin converting enzyme is diagnostic of hepatic sarcoid? Or D, an elevated serum alkaline phosphatase with normal or only mildly elevated aminotransferases is typical of hepatic sarcoid? And go back to our question stem.
So this is assigned to me.
Oh, well, let's just see who's
Oh.
answered.
Okay.
How people have answered. And then we can talk about it a little bit more. Shall we go see the responses? A little bit more variation here. The vast majority chose elevated serum alkaline phosphatase with normal or only mildly elevated aminotransferases is typical of hepatic sarcoid, but we have a couple other people who've chosen A and C. So we will turn to Dr. Kim to answer this question.
Thank you. And good morning from me as well. Thank you for attending this course. Really appreciate your participation. So I think that if you go back to the question, they give away the diagnosis. This is a relatively young person with cholestatic profile, enzyme abnormalities, and then there's a chest X-ray clue that this is sarcoid, and then ACE was elevated. So the diagnosis is not in question. So what do we know? What do we need to know about hepatic sarcoid? My brain capacity is always limited, so I try to remember 3 things about anything. So hepatic sarcoid is a part of systemic sarcoid, but it can be isolated in the liver alone. So in a board setting, I think it's expected that you will have bilateral hilar adenopathy, but in clinical setting, they don't necessarily have that. Second, it is a cholestatic profile, and the pathophysiology for that is thought to be related to the granulomas invading or compressing on bile duct and eliciting alkaline phosphatase or gamma GT response. And hepatic sarcoid is part of a number of entities called granulomatous hepatitis, that can be associated with infectious like Q fever. And there's an entity called granulomatous hepatitis that is sort of an idiopathic disorder. But not to confuse sarcoid with anything else, this feature of sarcoid may be given in the test. And for treatment, number 3, the classic treatment for sarcoid steroids, obviously, but in the liver, UDCA has been used, and that's because the alkaline phosphatase being elevated, and it can help, and it certainly is worth considering. So if you go back to the next page, so a diagnosis of hepatic sarcoid mandates initiation of corticosteroids. This is a sort of a test-taking strategy when the question says something is always true or something is always false. That's a red flag, right? It's very rare in medicine. It's 100%. So on that ground alone, I think A is less likely to be true. But as we just discussed, like everything, sarcoid treatment is risk-benefit calculation. So for people without serious hepatic fibrosis or crazy biochemical abnormalities, trying ursodeoxycholic acid would be a reasonable, and if they don't respond, consider steroid. That's what I do in my practice. Number 2, hepatic sarcoid is characterized by caseating granulomas in the liver. That's a giveaway. It's a non-caseating granuloma in sarcoid. And number 3, it is also the 100% question that is ACE always elevated in hepatic sarcoid. The proportion, I think, is variable. It's something like between 20 and 80%, depending on the report, but not always they are positive. So you need to have a high index of suspicion. And the correct answer, in my opinion, is the 4th one, that the clinical presentation is cholestatic profile with the only mildly elevated aminotransferase elevation, if at all. So that's D is the right answer to go with.
Great, thank you. That's a great point that you bring up, that it's never something that's mandated, or it's never this or always that, that it may be medicine is never 100%. So that's a good point for the boards. Thank you.
I've come this far with that strategy.
Great. We'll move on to our next question. A 27-year-old man with a history of schizoaffective disorder is found to have the following liver enzymes: AST92, ALT105, alkaline phosphatase of 80, bilirubin of 0.9, albumin of 3.0, and an INR of 1.2. His CBC is remarkable only for platelets of 99,000. And here the right upper quadrant ultrasound shows a normal gallbladder with no gallstones, a CBD again of 3 millimeters, and the liver is small with a nodular contour, and no liver masses are seen. Doppler study shows normal flow in the hepatic and portal veins, and there's moderate splenomegaly that's present. Which of the following tests would be compatible with the diagnosis of Wilson's disease? Serum non-ceruloplasmin bound copper less than 150, urine copper level of 180 micrograms per 24 hours, serum ceruloplasmin level of 60, white matter lesions on brain MRI, or antiphospholipid antibody titers of more than 1 to 2,500. So which of the following tests is most compatible with Wilson's disease? A serum non-ceruloplasmin bound copper level of less than 150, a urine copper of 180, a ceruloplasmin level in the serum of 60, white matter lesions in the brain, or antiphospholipid antibody titers that are high. Okay, we can go to the answers, see how people chose. Okay, a little bit of a mixed response here. Most people chose B, urine copper level of 180 micrograms for 24 hours, with a smattering of people choosing A and C. We will return to Dr. Kumari to go over why the answer here is B.
So again, as we talked about before, can we go back to the choices, Dipti?
Yep.
So once we have the suspicion for Wilson's disease, the first thing to be checked is ceruloplasmin, actually the choices. First thing to be checked is the ceruloplasmin level. If it is less than 20, 20 is the magic number, then the 24-hour urinary copper is checked, and it should be more than 100, which is the second one. But sometimes there is this confusion about copper level in the serum. You have to make sure they're asking serum or urine. In serum, it should be more than 250 micrograms, actually. And the white matter lesions, it's actually the lesions in the basal ganglia, which we talked about, not on the white matter. And antiphospholipid antibody levels, not related with Wilson's. So basically, again, we go back to the question again, they again put a young guy with a psychiatric disorder, and this question is actually checking the diagnostic algorithm. So ceruloplasmin level should be less than 20. Urinary copper should be more than 100. If we have that, then it's most likely specific and sensitive for Wilson's disease. And if that's not the case, and there is still high index of suspicion, then we go to the liver biopsy. Again, the magic number there is 250 for copper quantitative index in the liver biopsy. And if it is between 50 to 250, then we go for the genetic analysis for ATP7B. So that's the diagnostic algorithm. Any questions?
No, I think you had gone through it quite comprehensively earlier. So thank you again for relaying those important numbers that we have to remember to make that diagnosis.
Radhika, just one more point, I think, just in terms of answering questions without even knowing the right answer. So in general, ceruloplasmin is low, and then urine and serum copper levels are high. But answer A is just saying less than, whatever number they're giving. So it's not going to be probably a true answer, correct answer, because they're talking about the low serum couple level.
Yes, thanks for catching that.
Sure.
So yeah, that's the other point.
Great. Thank you, everyone. If there's no questions, we will move on to the next question. Okay, here we have a 48-year-old woman who is referred to you for evaluation of a 2-year history of unexplained elevated liver enzymes. Her AST is 67 and ALT is 83, and her total bilirubin is 0.8. Alkaline phosphatase is 99, and serum albumin is 3.9. Her CBC is normal. Further testing reveals that her Hep B surface antigen is negative, Hep B surface antibody is positive, Hep B core antibody is negative, and Hep C antibody is negative. ANA is also negative, as is anti-smooth muscle and AMA. Her iron studies are normal. She is alpha-1 antitrypsin phenotype MM. Ultrasound of the liver shows a large and echogenic liver with patent portal and hepatic veins and no radiographic signs of portal hypertension or cirrhosis. Her physical exam is notable for a well-appearing woman with abdominal obesity and acanthosis nigrans of the posterior neck. Her BMI is 37. Her past medical history includes the following diagnoses: type 2 diabetes, hypertension, polycystic ovaries, and obstructive sleep apnea. Her medications include insulin and amlodipine. She has no past or current history of alcohol use. So you discuss with the patient your recommendations for proceeding with a liver biopsy for diagnostic purposes. Which of the following are histologic diagnostic features of non-alcoholic steatohepatitis, NASH, in adults? A, portal lymphocytic infiltrate, steatosis, and endotheliitis. B, lobular inflammation, steatosis, and centralobular hepatocyte necrosis. C, hepatocyte ballooning, lobular inflammation, and steatosis. Or D, steatosis, Mallory-Hyland, and portal lymphocytic inflammation. I think for this question, we can go to the answer choices and see how people have responded. Okay, the vast majority chose hepatocyte ballooning, lobular inflammation, and steatosis, and someone changed their answer but had put A. So there's a little bit of confusion back and forth. So let's go to Dr. Wong and see what he would put for this answer.
Great, thanks. Yeah, wow, great job, guys. So C is the correct answer. Let's go back to the question stem again. This is, just for board taking techniques and such. This is one of those questions where, I like to read the actual question first before reading the question stem, because if you read the question, basically it's asking you if you can identify what histologic features are seen in NASH, and you can just skip the question stem really to save time, because the question stem is really painting a picture of a NASH patient with the characteristic clinical features. In the third paragraph, it's really telling you that all concurrent chronic liver disease is being rolled out in terms of viral hepatitis, autoimmune liver disease, antibody markers are negative. As alpha-1, Dr. Ghaziani mentioned later, normal phenotype, so that kind of makes that unlikely. Ultrasound findings sort of showing an enlarged, likely hepatomegaly with steatosis, and while not perfectly sensitive or specific, there's no signs of portal hypertension or cirrhosis on ultrasound. And then the clinical exam, again, is consistent with the picture of a NASH patient, but to be honest, doesn't really necessarily help you with the question. It's really painting a picture of a typical NASH patient. So then going to the question and the answers again. So tricky, you sort of have to know it, but some little clues, when you look at the questions or answer choices, you realize that all of them have steatosis. So just, from a test taking, technique, just ignore steatosis, because every answer has it. So that's not going to distinguish the difference between the correct and the incorrect answers. then you start looking at what are the differences between the answers. And you see here you have to know a little bit on what you generally see in certain disease states or conditions. So let's jump down to D, because that's something we talked about in a few questions earlier. You see Mallory-Hylands and Mallory-Dank bodies generally associated with alcoholic liver disease. Remember, we mentioned that. Not perfectly so specific for alcoholic, because sometimes it can be seen. So they're not unique to NASH. So I sort of cross that off. And portal lymphocytic inflammation, also not specific for NASH. So I cross that out. Answer A, endotheliitis. So that you generally see in the setting of rejection. And this is not really painting a picture of that. You're asking, what do you see in NASH? So I can cross that out. So you're left between B and C. And the difference here that helped me identify C as the correct answer is central lobular hepatic necrosis. So you see that, in acetaminophen, toxicity, drug-induced acute hepatic necrosis, not a feature of NASH. So even if you did not know it, by some degree, process of elimination, it can sort of guide you to C. And then looking at the features in C, those are typical features that you see in NASH: hepatocyte ballooning, lobular inflammation, and of course, steatosis. So C is the correct answer. And also, just as an aside, it sort of highlights the importance of liver biopsy as a diagnostic tool in accurately diagnosing NASH. Unfortunately, we don't have a biomarker. That's sort of the sort of multi-million-dollar question, is we don't have a serologic or any kind of non-invasive biomarker for distinguishing NASH from NAFLD without NASH. And liver biopsy still is the gold standard for identifying NASH. And these are the typical features that you would see in a patient with NASH.
Great, thank you so much. Are there any questions from any of the attendees? Please remember that you can type them into the Q&A box right there. We'll move on to the next question. This is the case of a 44-year-old male with known chronic Hep B, Hep B E antigen positive on entecavir, who develops jaundice and is admitted to the hospital. He has recently returned from a 2-month trip to Italy, Serbia, and Turkey. He takes hydrochlorothiazide chronically for mild hypertension, and his total bilirubin is 7.0. AST is 2045, ALT is 3010, and INR is 1.2. Over the first 24 hours, the following labs return. He is Hep B surface antigen positive. Hep B DNA is detected at less than 10. Hep A IgM is negative. Hep A total is positive. Hep C antibody is negative, and Hep C RNA is undetected. And ANA was checked and it's also negative. So what is the most likely cause of his acute icteric illness? Is it A, acute on chronic flare of hepatitis B, B, acute hepatitis A infection, C, superimposed hepatitis delta infection, D, medication noncompliance, or E, drug-induced liver injury? And here we'll go back to the question stem and take a look here. And again, the answer choices are, does he have A, acute on chronic flare of hepatitis B, B, acute hepatitis A infection, C, superimposed hepatitis delta infection, D, medication noncompliance, or E, drug-induced liver injury? Give everyone a few seconds to just take a look at that stem again. Okay, you can go to the responses. Everyone chose C, superimposed hepatitis delta infection. And we will turn this question over to Dr. Nguyen to help us answer why C is the answer here.
Thanks, Dipti. So everyone got the correct answer, and I think everyone already zoned into the major clues for this question. So you cannot really have acute on chronic flare of Hep B or medication non-compliance, which is choice A and D, because the hepatitis B DNA is suppressed, it's detected but less than 10. So basically that definitively ruled out those two. And then the other one that is also in the lab that they give us already is the hepatitis A. This cannot be acute hepatitis A because the hepatitis A total antibody is positive. So the patient is already immune. And it's very unlikely that this is medication induced because the patient is only on thiazide. So, and thiazide is not a common cause of liver of DILI. So I think in this case, everything else is clearly wrong. So just by process of elimination is C, superimpose of hepatitis D delta infection, even though we do not have any lab information to confirm that in this case, but we have a very good clue. The patient has a history of chronic hepatitis B. So this is not a co-infection together, but the patient has established Hep B, and then the patient traveled to the hotspots of hepatitis D. So Southern Italy, Southern Europe, Italy, Serbia, and the really big hotspot is especially Turkey. So I think this is a clue. So it's a combination of the clue from the history and then also the lab that help us nail down this question. Thank you.
Thank you. Yeah, I think they try to confuse you with all the information that they've given there. And they didn't even mention hepatitis delta in the question stem, but I think the process of elimination gets you to the right answer. Does anybody else have any comments regarding this question? Okay, then we'll move on to the next one. A 55-year-old man is referred to you for evaluation of elevated liver enzymes and abnormal iron studies. His AST is 70, ALT is 85, iron saturation is 88%, and serum ferritin is 1600. His CBC is normal. The patient feels well and is asymptomatic. His physical exam is normal with a BMI of 24 and normal blood pressure. He is taking no medications or supplements. He does not drink alcohol. His serologic testing is negative for viral hepatitis, autoimmune hepatitis, and alpha-1 antitrypsin deficiency. He is homozygous for the C2A2Y mutation. His liver ultrasound with Doppler is normal. What is the next appropriate step in the evaluation of this patient? A, commence phlebotomy. B, proceed with liver biopsy. C, begin iron chelation therapy. Or D, continue close monitoring and treat when he develops symptoms. So do we commence phlebotomy, do another liver biopsy, begin iron chelation therapy, or just monitor him for now until he develops symptoms? Okay, we'll go to the responses. Okay, a little bit of a mixed bag here, half and half. Half say commence phlebotomy, and the other half say proceed with a liver biopsy. So Dr. Ghaziani, what would you do in this situation?
Yes, Dipti. I think this is a tricky question, and I understand why there's almost half of people chose A and the other B. So if we go back to the question stem, please. As Dr. Wong said, we always look at the end of the stem and see what the question is, and then go back to the case itself. So looks like, if you show the question is, what is the next step in the evaluation of this patient, right? And sounds like we already have the diagnosis. If you look at the patient's presentation, is someone with mildly abnormal liver enzymes, ALT, AST. And it just tells you how we approach it. We went through this approach to chronic abnormal LFTs in other cases that were presented already. And the positive findings that are highlighted in this case that are relevant, just to kind of exclude the potential etiologies, And it shows that we have an abnormal finding in iron indices. The iron saturation is definitely elevated, 88%. If you remember, we mentioned that saturation over 50% in men or 40% in women is abnormal. Serum ferritin is 1600, is very abnormal. And they're also showing some features of other type of liver disease that, as you know, we can see secondary iron overload in even non-hemochromatosis patients, such as viral hepatitis, hepatitis B, C, even NASH. They can have mildly abnormal iron levels. So the BMI in this patient is slightly elevated. Dr. Wang might not agree because we usually see higher BMI with NASH. But then the autoimmune with viral hepatitis is negative. Also, alcohol is another cause for secondary iron overload. Patient doesn't drink. So we kind of ruled out concomitant liver disease. And then alpha-1 antitrypsin deficiency has been ruled out, and patient is homozygous. So the next step that they did is to test for HFE mutations to assess for hereditary hemochromatosis. So C282Y is the major mutation, and the H63D and S65C that also are tested, but they're minor and rarely lead to a phenotype, basically. If you look at the hemochromatosis patients, basically 75–80% of them are homozygous for C282, and the rest could be either heterozygous C282 plus the other minor mutations, or even non-HFE related hemochromatosis, such as the other genes that are involved in iron pathway, such as ferroportin, hepcidin, and etc. So I think we have a good diagnosis of the hemochromatosis, and the thing is we do not need to do a biopsy to confirm diagnosis of hemochromatosis. So look at the answers. So the first one is start phlebotomy, and then next one is proceed with liver biopsy. Why would we do liver biopsy? What's the indication of doing a liver biopsy? If you look at the studies, the older studies, they all show that if you do have cirrhosis, then the risk of liver cancer is significantly high if you have hemochromatosis. And that is really a game changer in terms of how we screen these patients for hepatocellular carcinoma. There's no guideline toward doing the regular screening for HCC in non-cirrhotic hemochromatosis patients. So that really changes that plan of management in these patients, and the risk of liver cancer in hemochromatosis is very high. It's like 20-fold increase if we do diagnose cirrhosis. So that would be the reason. And when do you do the liver biopsy? The indication that is usually talked about is when you have a ferritin level over 1,000. This patient already has like 600, ferritin of 600, which is very high. I would say in practice, it might be a little bit different now with the availability of non-invasive testing to diagnose cirrhosis or advanced fibrosis with elastography, but they don't give you the option of that. But the future board question, they might bring that one, instead of the liver biopsy at the first step. So your MR elastography or transient elastography might be helpful in terms of ruling out, diagnosing cirrhosis. And if you have this, findings in the gray area, you still proceed with the liver biopsy to rule out cirrhosis. Also, for phlebotomy, obviously, these patients has the indication of starting phlebotomy, but I think they wanted you to first rule out cirrhosis, and obviously at the same time you can plan for phlebotomies. When do you do the phlebotomy? Obviously, if patient has symptoms could be like, if the heart is involved, they have reduced ejection fraction, or they have ongoing abnormal ALT, AST, or ferritin is about 500, you're going to start the phlebotomy anyways, and that's the indication that you know, in these patients also applies.
Great.
Yeah, and then begin iron chelation therapy. We really do the iron chelation, especially it's not the first step unless patients is not able to tolerate phlebotomy at all. And we might go for this option. Obviously, these drugs have side effects and they're not very easy to use in practice. So it would be the next option. Continue close monitoring and treat when symptoms develop. Absolutely not. I think everybody agrees on this, that because of, well, if you don't start phlebotomy, even if they're not cirrhotic, there is a risk of progression of fibrosis, eventually developing cirrhosis and liver decompensation, needing for liver transplant, or developing HCC. So phlebotomy has shown to be the best treatment for hemochromatosis patient. Then, yeah, I don't know if there is anything else I haven't covered.
Great.
Yeah,
That was
please.
great. Thank you so much.
What if there was a choice of MRI with elastography?
I know, Ray. Yeah, I would. Well, that's what we probably do as hepatologists in practice. We're not going to do the liver biopsy right away because it's invasive, has complications. We do MR elastography, and if that is, doesn't show increased fibrosis, we would probably start with phlebotomy, and then if the ferritin level is down to the level we want, like, close to 100, and they still have abnormal FTs or they have symptoms, then it makes sense to do the biopsy. That's what I think we would do.
I think for the board purpose, in the right context, recognizing MRI as the initial test for iron quantitation before you order biopsy and iron measurement, I think may be relevant.
Yeah, I hope the questions will be modified for the next board. Yeah.
Great. We'll move on to the next question. The county health department reports an outbreak of hepatitis A traceable to a local restaurant with a past record of health code violations. Several patients report to your office concerned about exposure. Which patients are at increased risk to develop fulminant hepatic failure following an acute Hep A infection? Patients with chronic Hep C, patients with Hep B surface antibody positivity and core total positivity, children exposed to hepatitis A, patients with chronic renal failure, or pregnant women. We can go to the answers here. There's not much in the questions, Tim, so. Okay.
Wow. Okay.
Have a little bit of everything. We'll turn to Dr. Kim to help us go through which is the right answer here.
All right. So again, my three things about hepatitis A is that it's a fecal to oral transmission, so it tends to be epidemic. Second, there's no chronic form. It's only acute infection and it's detected by IgM. And third, severity of disease is higher in adults and perhaps in immunocompromised individuals. So here, let's go through the steps of elimination. Choice B is a normal individual, right? So this person doesn't have a disease, so we ruled that out. Children exposed to Hep A, that's actually a safer population where you don't develop fulminant disease. It's more common in adults. And that leaves us with A, C, and E. That sound like risk population. The board answer is A. Hepatitis C patients acquiring Hep A on top of that has been reported to develop fulminant liver disease. And in fact, at some point in the past, checking for hepatitis A used to be, it may still be a quality metric for patients taking care of hepatitis C. So that's the board question. Biological question, are people with chronic renal failure and pregnant women are at a higher risk of having worse outcome from acute hepatitis A? I suspect that is probably true, but choice A is the famous example that you're expected to know for board review, board taking. Pregnant women, hepatitis, pregnant women, that's a ding, 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 that's a hepatitis E clue. And rarely herpes simplex hepatitis, which is a really bad form of acute hepatitis, can also involve pregnant women. So those are the sort of a trivia that may come up in pregnancy. But for this question, A is the right one.
Great. Thank you so much, Dr. Kim.
Just want to point out something, Deepti, about while we're in the context of Hep A and acute liver failure, fulminant hepatic failure. Basically, Hep A is similar to acetaminophen toxicity with a great outcome, and they can have up to 60% spontaneous recovery without liver transplant need.
Great, thank you for that. Okay, we'll go to our next question. A 45-year-old woman with genotype 1A Hep C presents for reevaluation. She is treatment experienced and did not achieve an SVR after completing 8 weeks of sofosbuvir lidiposphere therapy 12 months ago. A transient elastography in the office today suggests that she has stage 3 fibrosis. What is the next best step? A, sofosbuvir, velpatasvir, voxeloprevir. B, NS5A RAV testing. C, sofosbuvir declarasphere. D, sofosbuvir lidiposphere for 24 weeks. So this is a woman who's had treatment experience and did not achieve SVR with sofosbuvir-based therapy with evidence of advanced fibrosis. So what is the correct answer here? We'll go to our answers. We get a little bit of a mixed bag again between A and B. We'll turn to Dr. Kim again for this question.
Very interesting. Full disclosure, I didn't write these questions, so don't blame me if you disagree with me. So my 3 things with retreatment for Hep C, we went into this in my talk, and that is potential concern for resistance. And the buzzword is RAS, resistance associated with associated substitutions. And in the retreatment setting, RAS is concerning NS5A product. So that's NS5A and resistance, that's number 1. Number 2, as this question tries to address, the preferred regimen for NS5A exposed patients is this triple combination Sulf-Vel-Vox. That's number 2. Number 3, there's no concern for resistance for interferon, ribavirin, or sofosbuvir. So those are the 3 points. So if you look at the bottom part of the slide, pegylate interferon ribavirin failures, you don't worry about resistance or you consider them as naive. Again, Sulf-Vel-Vox triple combination is preferred. And in cases of difficulty, like genotype 3 cirrhosis, always consider adding ribavirin. And the table above, I am not sure you will be asked about it, but this is for practice, this is sort of the ultimate regimens that if you fail the preferred ones, glipip or Sulf-Vel-Vox, what do you do? And the answer is to add sofosbuvir in certain cases or ribavirin. But anyway, let's go back to the question. So here, the right answer is a triple combination. And again, this is a situation where you answer the board question or apart from what you would do in your practice. So if you ask me, would you test this person for NS5A variant before you start the triple combination? I probably will say yes. And that's in case if she fails the triple again, then we have some information to go back to. But the board answer is the triple. And the reason for that is in the phase 3 trial that led to registration of the triple combination, the underlying NS5A RAS did not matter in terms of response rate. Uniformly, people got 97% or so response rate. So the right answer is you don't need to, if you're going to use the triple combination, you don't need baseline testing upfront. That's my answer.
Great, thank you so much. Any questions about this question from the attendees? No. All right, I think that's a very important diagram from your presentation, and you guys all have access to all the slides on the Stanford CMU website, so you can take a look at it at your own time. We'll move on to the next question. A 64-year-old man is referred to your GI clinic for evaluation of abnormal liver transaminases and jaundice. He feels unwell and hasn't been able to keep food down for a week. His past medical history is notable for diet-controlled diabetes and hypertension. He drinks a few beers on Sunday while watching football, but denies a history of chronic alcohol abuse. He recently returned from a trip to Texas to a gaming ranch where he and his friends hunted deer and wild boar. There were no recent antibiotic exposures. On exam, he has a low-grade fever, icteric sclera, and is mildly tender to palpation in the right upper quadrant. An ultrasound shows a heterogeneous liver echotexture without biliary dilation or gallstones. Laboratory studies are as follows. Hep A IgM is negative, Hep B DNA is negative, Hep C RNA is negative, and smooth muscle and ANA antibodies are also negative. What is the best treatment for this patient? A, observation, B, ribavirin, C, MRI, MRCP, or D, HIDA-scan? So we'll go back to the question here. And would you just observe this patient? Would you give him ribavirin, do an MRI, or do a HIDA-scan? Okay. And we get a mixed bag of answers, everything but HIDA-scan. We'll turn to Dr. Nguyen for this question.
Okay, so about half chose the correct answer, which is observation, and a mixture of the others. So the way I approach these questions is that the ultrasound show no evidence of dilation or gallstone. And also, we are not given any lab results here. So we do not know if alphos is more elevated or not. So no particular reason to really worry about biliary obstruction at this time. So MRI and HIDA-scan, I think C and D are very unlikely to be the answer. So the other two would be A or B, okay? So the reason that, you know, the fact that they put in ribavirin kind of give you a clue that this may be hepatitis E, okay? Because ribavirin is a treatment for chronic hepatitis E at this time. But this case is the key here is the history of hunted deer and wild boar. So hepatitis E is endemic in many different areas of the world, but not in the US. So in non-endemic areas, it's usually just a zoonotic infection that people get from contacts with infected pigs or deer or wild boar. And acute hepatitis E is usually subclinical, like acute hepatitis A. They're usually subclinical, and they usually do not cause mortality. Even though Hep E mortality for acute infection is higher than Hep A, but it's still about 1% or less. So in general, it's self-limited. So for acute hepatitis E immunocompetent patients like this gentleman, then the treatment is like with hepatitis A, supportive care. And then, you know, the patient will have constitutional symptom, yellow for several weeks or few months, and then will be fine. Now, ribavirin is treatment for chronic hepatitis E, which occurs in about 60 to 80% of patients exposed to it and get acute infection who are immunosuppressed, usually organ transplant patients. We don't see that in liver transplant as much. The chronic Hep E infections that I have seen are usually from kidney transplant or lung transplants, other organs that requires higher long-term immunosuppression. So the definition for chronic Hep E infection is 3 months or longer of viremia. And the very important point to remember is that the first step of treatment, even for chronic Hep E in immunosuppressed transplant patients, is still not ribavirin. The first step is to reduce immunosuppression, because a lot of patients that can take care of the HCV viremia. So that's also another favorite board questions. What is the first step of treatment? Reduce immunosuppression or ribavirin? So the correct answer would be reduce immunosuppression. If that does not work, then ribavirin for about 12 weeks. Studies have reported anywhere between 12 to 24 weeks, and the success rate anywhere from about 40 to 80%. And the diagnosis in this case, in the past, it was difficult to get Hep E RNA, but now it's not very difficult. So that's the best way to diagnose this, is to get a Hep E RNA, because the Hep E serology, whether IgM or IgG, it has false positive and false negative. So it's not as helpful.
Great, thank you so much. Any questions about this or any other comments on this question? Okay. We'll move to the next question, which I think will have to be our last question, just because I think we're running a little bit low on time. So here we have a 50-year-old man from Kenya who presents with elevated liver enzymes. As part of his evaluation, you send lab investigations that reveal Hep C RNA of 2 million and an HCV genotype of 2B. His AST is 90, ALT is 120, total bilirubin is 1.2, and creatinine is 0.9. HIV antibody is negative, Hep B surface antigen is positive. Further testing shows that his Hep B DNA is 10 million. Elastography is consistent with F2 fibrosis. What is the next best step in management? A, start sofosbuvir velpatasvir for 12 weeks with weekly monitoring of Hep B DNA. B, start sofosbuvir and lidibasvir for 12 weeks with monthly monitoring of hepatitis B DNA levels. C, start glecaprevir, piperbanitosvir times 12 weeks with no monitoring of Hep B DNA. Or D, start tenofovir, 25 milligrams daily. Go back to the question. So a patient that has both hepatitis C and hepatitis B with F2 fibrosis. Okay, we'll go to the answers. Most people chose D, and some people chose A, and we will turn to Dr. Nguyen to give us the answer to this one as well.
Okay, so most people got the correct answer, which is to treat the hepatitis B first. Normally, if it's just surface antigen positive, we don't have to start the Hep B treatment first. But in this case, it's very high viral load, so you could, argue that you should bring down the Hep B a little bit first before you treat the Hep C. But in practice, a lot of time we start this at the same time as treatment with hepatitis C. So this is a case that they give you a lot of information, and most of it is not very necessary, really. The main information you need to know is that this patient has RNA positive, and that the patient also have chronic Hep B infection, surface antigen positive, and DNA is very high. So when the patient, Hep B and Hep C co-infection, usually, this is actually quite unusual that this patient have very high viremia in both Hep B and Hep C. Usually one virus dominates. So you will either have high Hep C RNA or high Hep B DNA, but not both this high like this. but let's assume this is a real case. So this patient needs to be treated for both, obviously, and Hep B DNA is very high. So this is pretty clear-cut. If the patient has surface antigen positive, the patient should be treated for Hep B and not monitoring. Now, if the patient is Hep B surface antigen negative, but core antibody positive, this patient could also reactivate, but the risk is much, much lower. So in the setting of DAA treatment for Hep C co-infection, prophylactic treatment for Hep B is not needed. So A, B, and C are not correct answers because it implies that you just start Hep C treatment and monitor or no monitoring of Hep B DNA. So A, B, and C have to be wrong, and D is the correct answer. And Dipti just put up a summary. Basically, this is a Hep B reactivation kind of in a nutshell, so to speak. So in all immunosuppressed patients or patients who undergo HCV co-infection treatment with DAA here, we need to check for Hep B surface antigen as well as core antibody. You could also check for surface antibody, but one thing to remember is that whether surface antibody is positive or negative, the patient can still reactivate if they are core positive. The surface antibody positive patient have a little bit lower risk, but it is still there. Basically, the easy and quick way to remember, or things that I could remember off the top of my head, is surface antigen positive or DNA positive. Basically, you start prophylaxis and you use one of the new nukes, not lamivudine or adefovir, but entecavir, TAF, or TDF. And continue, this is a very important point, continue for at least 6 to 12 months after the end of the chemotherapy or immunosuppressive therapy. Because I have seen a lot of time people get started and then they stop too early. And in my practice, I usually continue for 12 months instead of 6 months, because there are cases of delayed reactivation. Now, if the patient get an anti-CD20 like rituximab, or something similar to that, which is very commonly used now, not just in oncology, but also in in inflammatory conditions, in dermatology clinic, in rheumatology clinic. So if the patient get an anti-CD20, then you need to treat for at least 12 to 24 months after the end of immunosuppression. So because a delay reactivation is well reported, like 18, 24 months in many cases. Now, the tricky one is the isolated core. So the surface antigen and DNA positive, that is much more clear-cut, that almost everybody need to be prophylaxed. And the key thing to remember is not to stop too soon after the end of chemo or immunosuppression. But for isolated core, the majority do not need to be prophylaxed with Hep B treatment right away, unless they are stem cell transplant or anti-CD20. So these patients, whether they are surface antibody positive or negative, if they are core positive, they must start prophylactic NUC and also continue for 12, 24 months or even longer in case of stem cell transplant patients. The difficult part is the isolated core, but on kind of moderate risk immunosuppression. For example, prednisone 30 milligrams a day by itself for a week or two does not warrant immunosuppression. Or if the patient just take Remicade alone by itself, does not automatically dictate that the patient needs to be on Hep B treatment. But the problem is twofold. One is that the disease of the primary disease, like say the IBD disease or the rheumatoid arthritis, can get worse than people would add prednisone on top of another medication. So in combination, they can become too much and the patient would be at higher risk. Or the other thing is that the monitoring, it is probably not practical to be asking the patient to get blood tests every 1 to 1 month or even 3 months. If this is a medication, the patient needs to be on lifelong. So you have to take into the account of the feasibility of monitoring, and also monitor if other things are added, and then and the new prophylactic medication become indicated at that time. And the DAA treated HCV, which is this case we already discussed. If the patient is core positive only, then the patient just need to be monitored up to 12 weeks post-treatment. And then we just treat if the surface antigen or DNA become positive. But these are generally pretty rare.
Great. We have one question here about when is it safe to start treatment in this patient? Once you, how low does the Hep B DNA have to be in order to start treatment for the Hep C?
Yeah, good question. If the patient is core positive only, then you just start the treatment at the same time with chemotherapy. If the patient is hepatitis B DNA positive, there's really no threshold that you need to wait for. So it should take into account. So let's say if the patient has an aggressive cancer that waiting for 2 weeks or even for 1 month can cause progression. Like some patients have very rapidly progressive lymphoma or melanoma or something like that, then I probably would start both at the same time. Start the Hep B right away and start the chemo at the same time. If it is like a indolent cancer that can wait, and the patient DNA is 500 billion, then it may be better to start the Hep B treatment and maybe wait for a month or something and then start the other one. So this is to go case by case, but there's no fixed threshold that we have to wait for. Medication for Hep B now is very potent. And if we are worried, we can throw even 2 at a time. Sometimes I give patient tenofovir and entecavir up front, and then we just withdraw 1 later in such a cases. But usually that's not necessary. But when we are desperate, we can do that initially.
Great, thank you. So in this patient who is Hep C we're trying to treat, would you would you start simultaneously or?
Probably can start simultaneously because DNA of 10 million is high, but it's not, it's not 500 million or billion range. And tenofovir is pretty potent, and the patient should be monitored. So you can start the same time, or you can start tenofovir first and start the other one in a month. You can do both ways. But then one can also argue that there's no reason to rush into it either. And if you feel better for DNA to be lower, then you can go with the tenofovir for a month first. The key thing to remember, as I have seen in practice, is that you can order the tenofovir both for reactivation for chemo and this too. You can order it, but it may not be approved right away. So some people actually ended up getting the chemo first, and the tenofovir prescription is still not approved by insurance and would lag. So in the case of patient with low viral load or just core positive, then that's not a big deal. But in a patient with active hepatitis B, and if the lag time is too much, then that could be a problem.
Great, thank you so much. I think we're running out of time, so I think we'll leave it at that. Thank you to all our panelists for joining us today and for such a lively discussion. We will take a break, and the next session will start. Oh, we're really late. We'll start in a few minutes with liver session number 2.
Okay, I think we can get started with this session. That's right. So introductions, and then get moving with the questions, and we will end on time, if not a little early, hopefully. So this is Disorders of the Liver, session 2. And we are, this is the list of our faculty today. So Amanda Chung is a clinical assistant professor and transplant hepatologist who is based at our Emeryville location. Tammy Doherty is a clinical associate professor and transplant hepatologist who heads our living donor program and the transplant program at Renown in Reno, Nevada. Renu Dhanasekaran is an assistant professor whose research in liver cancer has been funded by Career Development Awards from the ACG and NIH. Deepti Chonamraju is obviously our esteemed course director for our co-course director for this board review course. She's a clinical assistant professor and transplant hepatologist who heads our liver disease and transplant program at our Valley Care location in Pleasanton. And Aparna Goel is a clinical assistant professor and transplant hepatologist with a specific interest for this course in autoimmune and cholestatic liver diseases, although that's just one of several interests, I think. And I am Allison Kwong. I'm also one of the transplant hepatologists here at Stanford. So we can start with the questions. The polling system and setup and Q&A is all the same as the past couple sessions, so hopefully you are familiar with the way things are set up. So we'll just get started here. A 27-year-old man with newly diagnosed well-compensated cirrhosis due to primary sclerosing cholangitis presents for initial consultation. His past medical history is notable for ulcerative colitis that is well controlled with mesalamine. He feels well and has no specific complaints. His AST, ALT, total bilirubin, albumin, INR, and platelet count are all normal. His alkaline phosphatase is elevated to 347. Which of the following do you recommend for further management of this patient? Liver biopsy to grade and stage his PSC, ERCP to assess for progression of his biliary strictures, annual ultrasound evaluation of the gallbladder, initiation of ursodeoxycholic acid at 30 milligrams per kg per day for colon cancer prevention. You should see the options on the poll everywhere, but you've got liver biopsy, A, liver biopsy, B, ERCP, C, annual ultrasound, or D, ursodeoxycholic acid. I think I can see that. Let's see what we've got here. Okay, so you can change your choice. All right, Aparna, I think you're up for this one.
Yeah, so 2/3 of everyone got this right. So this patients with PSC are at risk for gallbladder cancer. And the lifetime risk is still not as high as that of cholangiocarcinoma or colorectal cancer. So it's about 1 to 3% lifetime risk of gallbladder cancer. So an annual ultrasound of a gallbladder is recommended. The risk for cholangiocarcinoma, the lifetime risk of cholangiocarcinoma and colon cancer, especially in a patient that also has ulcerative colitis, is much higher than that. In terms of the other answer choices, so a liver biopsy in this patient is really not necessary. It's already been established that they have cirrhosis, so getting a biopsy won't really provide any additional information to guide your management. An ERCP and PSC is warranted if you're worried about bacterial ascending cholangitis or if you're worried about a cholangiocarcinoma. But just for the sake of diagnosing or staging PSC, it really does not add additional value and may actually be harmful to the patient to do, as the contrast sometimes serves as a nidus for infection in these patients. So in the setting of pretty stable PSC without specific concerns, we wouldn't pursue an ERCP. And then lastly, ursodeoxycholic acid hasn't really been shown to impact the natural history of PSC, especially in more advanced stages of diseases, F3, F4 disease, so more advanced fibrosis. And at doses higher than or doses at 28 to 30 milligrams per kilogram, that there's actually a higher risk of mortality in these patients. So high doses of ursodiol should be avoided in all patients with PSC. If you go, the review on the next slide just talks about the overall screening management that we do for our patients with PSC. And someone that has cirrhosis, their risk of hepatocellular carcinoma still exists. So we do Q6 month screening, just like anybody else that has cirrhosis, with cross-sectional imaging ideally. The gallbladder cancer we talked about, so a yearly ultrasound is recommended, and a cholecystectomy should be performed if a polyp is over 8 millimeters in size, because those tend to harbor more adenocarcinomas. cholangiocarcinoma. So the risk of cholangiocarcinoma in a patient's lifetime, that in a patient with PSC's lifetime is about 20%, which is quite high. So it is recommended that we do at least annual MRIs with a CA 19-9. And the risk of colorectal cancer in someone that also has IBD is about 20 to 30% as well. So in anybody that has both PSC and ulcerative colitis, a yearly colonoscopy is recommended.
Aparna, I feel like this comes up every year, but if you're doing the MRI, do you still have to do the yearly
So
ultrasound?
that's a very good question. So the guidelines haven't been updated yet, but our radiologists at Stanford will call you and they'll say the MRI is pretty good at detecting small polyps and definitely will detect polyps that are over 8 millimeters. So our radiologists do not recommend anymore that you get the ultrasound in addition to the MRI because the MRIs are high quality enough now. The technical guidelines, though, haven't been changed yet to take the ultrasound out for annual screening. So I think that if you're at a place where the radiologists feel comfortable with the quality of the MRIs in terms of detecting polyps in the gallbladder, you probably don't need to get the ultrasound in addition to the annual MRI. But if you are having difficulty with higher quality MRIs, or if for whatever reason a patient can't tolerate MRIs as well and isn't necessarily getting them routinely, then you still should be getting the ultrasounds.
Okay. Or if you're taking your GI boards.
Correct.
All right, thanks. So we'll move on to the next question. So a patient is referred to you for management and follow-up of recently diagnosed compensated cirrhosis and no history of GI bleed. As part of the workup, you obtain an upper endoscopy. This looks normal without evidence of varices. Which of the following is the next best step in management? A, obtain portal pressure measurements. B, non-selective beta blocker. C, PPI. D, EGD in 2 to 3 years. So, compensated cirrhosis, portal pressure measurements, non-selective beta blocker, PPI, or endoscopy in 2 to 3 years. All right, I think we can look at our options here. I like seeing those numbers change in real time. Okay, I think we're good. So Amanda, I think we can.
Okay, so no one picked portal pressure measurements, but which is not the correct answer. But they can, if you happen to have them, they can prognosticate or determine the likelihood of developing varices. So usually at 10 millimeters of mercury, you'll develop varices, and at 12 millimeters of mercury, you're more likely to bleed. The non-selective beta blockers are indicated for primary prophylaxis in somebody who is found to have varices, but it hasn't been shown to prevent the formation of varices. So in this patient that doesn't have any varices on your screening endoscopy, you wouldn't start a non-selective beta blocker quite yet. And then with the normal endoscopy, there's no role for a PPI in this patient. So for this question, asking about the appropriate management of a patient that does not have any varices on your endoscopy, the correct answer is D, to do an EGD in 2 to 3 years, as long as they don't decompensate within that time period.
Awesome, pretty straightforward. Great, I think we can move to the next question. So a 32-year-old woman with a history of hypothyroidism presents to the ED with a complaint of fatigue and jaundice. Her exam is remarkable for moderate right upper quadrant tenderness on palpation. Laboratory test showed white count of 11, hemoglobin 11.1, platelets of 100, AST 131, ALT 155, alkalis of 109, total bilirubin 4.1, albumin 3.0, total protein 8.9, and INR 1.2. Ultrasound shows normal gallbladder with no stones, pericholecystic fluid or gallbladder wall thickening, CBD of 3 millimeters, liver small size with nodular contour without liver masses. Doppler study shows normal flow in the hepatic and portal veins, moderate splenomegaly, ANA is 1 to 2,560. Which of the following therapies would be a component of the initial treatment of this patient? Azathioprine, cyclosporin, ursodeoxycholic acid, tenofovir alafenamide, spelled with an A, two, has 3 A's, cyclophosphamide. All right, so your choices are azathioprine, cyclosporin, ursodeoxycholic acid, tenofovir alafenamide, and cyclophosphamide. You can look at the answers now. All right. So this looks like an autoimmune question. Parna, you are up.
Yeah, definitely. Definitely a patient with autoimmune hepatitis. So just, we'll talk about some clues that kind of give it away, but just remember that autoimmune hepatitis, the things that, you sort of are worried about, or just sort of clue you into the diagnosis are elevated transaminases, positive autoimmune serology. So this patient had a positive ANA, and then you're not given, I think, immunoglobulin levels for this patient, but you might be on the boards. And if the IgG level is high, or total protein was high here, so maybe there was a globulin gap as well. Yeah, there's a globulin gap. So you do see that there's elevated elevated globulin, so that sort of points to potential autoimmune disease as well. So the other things that in her history that make her higher risk of having autoimmune hepatitis compared to other diagnoses are her gender. So she's female. There's about 3.5 to 4 to 1 female to male ratio for autoimmune hepatitis. And then her history of hypothyroidism, so another autoimmune condition that sort of clues you into potential autoimmune hepatitis. And just remember that patients with autoimmune hepatitis can present along the spectrum of liver disease. So they can present with asymptomatic transaminase elevations to acute liver failure, or acute hepatitis with symptoms including jaundice and arthralgias and whatnot. So this patient, as she's presenting, appears to have cirrhosis, with her platelet count being low, with the albumin being low, and her ultrasound showing some splenomegaly already. And that unfortunately, cirrhosis is present in about 1/3 of adults that are presenting for the first time with autoimmune hepatitis, and about 50% of children that present with autoimmune hepatitis. So a biopsy would be warranted in her, but that's not what this question's asking you. This question's asking you what the first course of treatment is going to be. So there's 2 potential options for treatment for someone like this. One is to only use steroids up front and to see how they respond, so prednisone or prednisolone. And the other one would be to do a combination of azathioprine with steroids. And doing the combination allows you to use lower doses of steroids and potentially save some of the or reduce some of the steroid side effects of the steroids over the long term. This is not applicable for this question, but in a patient that does not have cirrhosis, budesonide would potentially be an option as well. But in a patient that has cirrhosis, we would not be offering budesonide as a treatment option. And then some of the other options that are listed here could potentially be used in patients. Actually, just one other option could potentially be used in patients that fail therapy. So don't respond to first-line therapy, meaning don't respond to steroids alone or steroids plus azathioprine. So cyclosporin is an option if you have an incomplete or if you feel a failure to respond to first-line therapy. Ursodeoxycholic acid has no role in the management of autoimmune hepatitis. There are patients that have overlap disease with PBC, and you sometimes have to add therapy for PBC. And then tenofovir, obviously, for the management of hepatitis B, which we're not concerned about for this patient. And cyclophosphamide, I think they're just trying to throw you off with a name that sounds like a calcineurin, but it's not really. So a chemotherapeutic agent would not be the appropriate answer here.
All right, thanks, Aparna. This was pretty straightforward, I think, too. All right, can move to the next one. A 50-year-old man presents to the ED with hematemesis and melena. He reports frequent episodes of abdominal pain. He drinks approximately 1 pint of whiskey daily and has done so for more than 20 years. His exam is remarkable for epigastric tenderness. Labs show AST of 105, ALT 60, alkaline phosphatase of 110, total bilirubin 1, albumin 3.8, INR 1. Right upper quadrant ultrasound shows normal gallbladder without gallstones, pericholecystic fluid and gallbladder wall thickening. CVD was 3, liver mildly enlarged with no liver masses seen. Harbor scan shows F2 fibrosis. EGD reveals large funded gastric varices without esophageal varices. What is the most likely cause of his varices? Portal vein thrombosis, splenic vein thrombosis, hepatic artery thrombosis, hepatic vein thrombosis, or sinusoidal obstruction syndrome? This question always gets me because it looks like you got a fiber scan in the ED, which doesn't seem very realistic, but maybe you've got one like the week before in the office. All right, so you've got so your first 4 options are some kind of vascular thrombosis, portal vein, splenic vein, hepatic artery, hepatic vein, and then sinusoidal obstruction syndrome. Okay. Take a look. All right. Excellent. Splenic vein thrombosis is the okay, yeah, so we can go into why. Let's go back to the stem. We can take a look at why. So I think GI boards loves this question because it's kind of it's a liver question, but more of a GI question. So it covers a range of possibilities, and so this is splenic vein thrombosis or isolated gastric varices that's without really much evidence for cirrhosis or liver disease. So where's the problem? So this is splenic vein thrombosis seen usually in chronic pancreatitis or after a pancreatic surgery. And so they give you a history of someone who drinks a lot and has frequent episodes of abdominal pain. So that suggests that this patient has either a history of recurrent acute or chronic pancreatitis. So that's what they want you to recognize. Treatment-wise, the non-selective beta blockers extrapolated for portal pressures and variceal bleeding is a good first step for prophylaxis. In the acute setting, maybe if they've bled, then these can't be banded, but maybe you can glue if your center has glue. If they have portal hypertension or like cirrhosis, since many of these patients also have a pretty significant alcohol history, you could consider something like a TIPS, and if IR is at your center, it can also offer BRTO or balloon occluded retrograde transvenous obliteration. So there are a few tricks IR can try to do if these bleed, but we don't, other than beta blockers, there's not a ton we can do when we see this entity. But what this question is asking is essentially to recognize this patient doesn't have the fiber scan you got shows only F2 fibrosis, not F4 or cirrhosis. So the cause of the varices is not cirrhosis, it's something farther down the line than this problem in the splenic vein. As far as the other questions, he could have a portal vein, or other options. He could have a portal. It could be an issue in the portal vein. In theory, although he doesn't have cirrhosis, so that's which is the major risk factor for portal vein thrombosis. So that's less likely. And then hepatic artery thrombosis, no reason he would have a problem in the artery. Hepatic vein thrombosis, they're getting into Budd-Chiari, which wouldn't cause necessarily isolated gastric varices. You would see other signs of portal hypertension. And then the last option, sinusoidal obstruction syndrome, will show up later. That's just a distractor. Okay. Next question, unless there are other questions, nothing in the Q&A yet. All right. So a 24-year-old woman is 34 weeks pregnant and seeking prenatal care. She has one child with chronic hepatitis B. This is her second pregnancy and it has been uneventful thus far. She emigrated from mainland China 1 year ago. Her blood work shows positive hepatitis B surface antigen, negative surface antibody, negative E antibody, hepatitis B DNA level of 300 million, AST of 19, ALT 29, INR of 1, albumin 3.5. What is the next appropriate step? A, initiate tenofovir therapy. B, initiate pegylated interferon alpha 2B therapy. C, watchful waiting, monitoring liver enzymes. D, hepatitis B immune globulin and HBV vaccination for the mother. Or E, screen for HCC. This is a pregnant woman, 34 weeks, third trimester, the very high viral load. All right, let's look at our answers. Oh, 100%. Deep T, it's an easy one for you.
Yeah. Okay, great. Everybody got the right answer here. So basically, if you go back to the question stem, this is a question that is looking at the risk of mother to child transmission of chronic hepatitis B infection. They give you a woman who has emigrated from an endemic region, who already has one child who has chronic hepatitis B, likely transmitted from mother to child, and now is in her second pregnancy. She clearly has a very high viral load, but her liver enzymes are normal and her synthetic function is normal as well. So in this patient, we know that high viral loads in mom increase the risk of transmission to baby, usually at the time of labor and delivery, and that we have good post-exposure prophylaxis with HBIG and Hep B immunization for the baby within 12 hours of birth. But despite that, transmission of hepatitis B can vary from a low of about 3% with post-exposure prophylaxis to as high as 9 to 10%. And that's usually in patients who have a very high viral load, moms with very high viral loads. So there are guidelines that suggest that for moms in the third trimester, if they have a hepatitis B DNA viral load greater than 200,000, it makes sense to treat them in an effort to reduce this risk of transmission to the baby. And then they're giving you a few different options of what you might treat with. And I think treating with pegylated interferon in a pregnant woman is a no-go. So you could remove that as an option. And then I believe they gave you both tenofovir and, they only gave you tenofovir, but they could have given you entecavir. And here the variation would be that entecavir is based on the old FDA classifications as a class C drug. So it's not really recommended in pregnancy, whereas tenofovir is a pregnancy class B drug, where it is more suitable for pregnancy. FDA did change their labeling, so they're not going by the letter grades. It's called the Pregnancy, Lactation, and Labeling Rule now, which is a more descriptive form. So, but in terms of pregnancy classifications, it's the old class B drug that you would want to give, which is tenofovir. They also give you the option of Hep B immune globulin and Hep B vaccination for the mom. That would be the appropriate action to take for the infant at the time of birth or soon after birth, but it will not do much for the mom who already has a very high Hep B viral load. And then they gave you screening for HCC, which is kind of a confounder here. Our guidelines would suggest that in a non-cirrhotic woman that you would not start screening until after age 50.
Great. Okay. Yeah, and this is an immune tolerant patient, right? So if she weren't pregnant, we would not necessarily need to treat or consider her for a clinical trial. But all right, this was our first, I think, 100%. So that I think pretty straightforward. All right, the next question. A 23-year-old previously healthy woman presents with new onset abdominal pain, abdominal distension, and lower extremity edema. She has no past medical history. Her only medication is oral contraceptive pills. She takes no supplements. She does not smoke or drink alcohol. Her labs reveal AST 256, ALT 211, alkaline phosphatase 214, total bilirubin 1.3, and INR 1.0. Serologic testing is negative for viral and autoimmune hepatitis. Pregnancy test is negative. On physical exam, her abdomen is distended with a discernible fluid wave. She has 1+ bilateral lower extremity edema. She's alert and oriented ×4 with no asterixis. Which of the following is the next most appropriate test to make the diagnosis? Liver biopsy, hepatic ultrasound with Doppler, hepatic arteriogram, MRCP. Go back to the stem. She's got new ascites, abdominal pain, oral contraceptives, elevated liver tests. So we've got liver biopsy, ultrasound with Doppler, arteriogram, and then MRCP. Okay, take a look at the answers. And our results. Have we got results? Or has no one voted? The poll has frozen, it appears. Okay. Well, I'm going to give you all 100% on this one. I suppose we'll move. The answer here is ultrasound with Doppler. So I always think the answer to any workup for elevated liver test should be an ultrasound with Doppler. So that's specifically to look at the hepatic vasculature and make sure you've got patent, portal vein, hepatic artery, but in this case, the hepatic vein is the problem. So this is a case of Budd-Chiari, and they want us to recognize that that can be, or that is diagnosed by Doppler ultrasound, which will be able to tell you if the hepatic veins are open or not. And the presentation is consistent. She has new ascites, and edema, and then is on oral contraceptive pills. So that's your suggestion that it's a thrombotic issue, and most often that is the problem is in the hepatic veins. Often these patients, and the standard is a Doppler ultrasound, but often these patients end up getting some kind of cross-sectional imaging either to confirm, or they're in the ED and they've gotten the cross-sectional imaging instead of the ultrasound. That will still also show problems in the hepatic vein if there is a thrombosis there. The nice thing about cross-sectional imaging is that it gives you a little more information than the Doppler ultrasound just telling you if the hepatic vein is thrombosed. And there, because of the issue being a problem with the drainage of the blood flow from the liver, you can see these pretty typical findings on cross-sectional imaging. So some of these are buzzwords for the board. So caudate lobe hypertrophy, that happens because the caudate has separate venous drainage. So when venous drainage from the right and left lobes are blocked, and the caudate lobe hypertrophies because all the blood is able to go from the caudate straight into the IVC instead of the blocked hepatic veins. And then you'll also see a lot of collateralization. So what that's called spider web appearance, and just generally the perfusion of the liver, the blood's trying to get out in some way around the hepatic vein thromboses. So you see heterogeneous perfusion. So all these are kind of keywords you might see if you're given a case of Budd-Chiari and some kind of imaging that should trigger some thought that, oh, that the problem's in the hepatic vein and we're dealing with a case of new Budd-Chiari syndrome. The other answers were arteriogram, which, you know, the problems in the hepatic vein, not the hepatic artery. MRCP obviously looks at the biliary system, not the vessels. You know, if the answer had been MRI plus MRCP, maybe that would have shown you the diagnosis too, but the option was just MRCP. And a liver biopsy in these cases is not helpful and probably just risky. So not the first step in workup for elevated liver tests. The ultrasound with Doppler should be, and that would show you the diagnosis before you're reaching for a liver biopsy. Okay. Any questions about that? Let's see. Hopefully we can get the poll everywhere up for the next question. Let's see. I think we can move to this one. 62-year-old man is referred for a second opinion regarding primary sclerosing cholangitis. He presented with jaundice and vague abdominal discomfort 3 months prior, and PSC was diagnosed after characteristic features were noted on ERCP. His medical history is otherwise remarkable for coronary artery disease and excisional biopsy of an enlarged supraclavicular lymph node 1 year ago with nonspecific findings on pathology. He is up to date with cancer screening and had an unremarkable colonoscopy 2 years ago. His physical examination is remarkable for jaundice. His labs show hemoglobin 13.4, white count of 7.5, ESR 62, AST 35, ALT 39, alk-phos of 555, total bilirubin 5.4, and a CA19-9 of 18. You recommend MRCP, which reveals stricturing of the extrahepatic common bile duct, a prominent distal bile duct stricture, and enlargement of the pancreas. What is the next best step in evaluation of this patient? Oh, it looks like our polls are working again. So check the serum IgG4 level, ERCP with biliary brushings for cytology and FISH, endoscopic ultrasound to assess the pancreatic head and distal common bile duct, PET scan, and refer for hepaticojejunostomy. Oh, it looks like it's working, but apparently it's not exactly working yet. So you could put it, there's a chat function if you want to put your answers in there, or we will reveal the answer in about 5 to 10 seconds. Oh, now it's working. Okay, let's give it a try. I'm getting live updates. Can we give the poll everywhere a try? And go to the, see if we can go. Oh, we've got some answers flowing in. Excellent. All right, Taprana, I feel like this is a new question, or like one of, a recent,
Yeah. Oh, wow. Okay, so a little bit split between these answer choices. So we'll talk about this in detail then. So this patient definitely has a sclerosing cholangitis, right? So the cholestatic abnormalities in their liver test, the alkaline phosphatase is high, the MRCP shows that there's clear stricturing in the bile duct. I think that there's two things that are sort of red flags for whether or not this is a true PSC in this case. The first is that there's an abnormality in the pancreas, the enlargement of the pancreas, and the second is that this patient has a history of lymphadenopathy, so some sort of some potentially another process that was going on. So remember that primary sclerosing cholangitis, in order to be diagnosed, you really have to make sure that there's not a second etiology. And it is recommended that in all patients with a primary sclerosing cholangitis that you do check IgG4 levels, because you'll detect it in a significant proportion of patients too. So the presence of the pancreas, the history of lymphadenopathy, both sort of suggest that it could be an IgG4 related disease. Remember, this is a systemic disease that has, it's sort of characterized by pretty extensive IgG4 positive plasma cell infiltration and T cell infiltration, which causes fibrotic lesions and this obliterative phlebitis. So it can affect the pancreas, affects the bile ducts, the gallbladder, salivary glands, the retroperitoneum, the lung, the kidney, and very frequently we see lymphadenopathy associated with it. It's unfortunate that the excisional biopsy, the lymph node for this patient was non-diagnostic previously. Remember that it tends to occur in older men as well. And he sort of fits the demographic of it as well. So the other answer choices are not necessarily things that you wouldn't do after. But remember, this is asking us what the next best step is in evaluation. So in anybody, remember that you're considering a sclerosing cholangitis diagnosis for, you need to check an IgG4 level. And especially in someone that has potential other clues that this could be another secondary cause of a sclerosing cholangitis. Remember, the treatment for this is very different than it would be for PSC. IgG4 associated cholangiopathy is very steroid responsive. So this patient would benefit from treatment very differently than if you were going to diagnose with PSC to begin with. Not to say that eventually you might not need to do an ERCP to take a look at the bile duct stricture. You might need to do an EUS to take a look at the pancreatic head. But the next best thing in this case would be to check a serum IgG4 level, the least invasive test possible.
Yeah, Aparna, I feel like this is a relatively recent addition to the boards, because I think when I took boards, I don't think this would have been fair game, or IgG4 disease may not have been fair game, but now it's pretty established.
Yeah, I think I honestly I can't tell you when it would have been added to the board. That IgG4 related disease has been around for a fair amount of time, and we've known about IgG4 associated cholangiopathy for a very long time as well. I think that it's very clear now that when you are thinking about the diagnosis of PSC, that you have to check a serum IgG4 level. So that has that is definitely guideline recommended now.
Yeah. Seems pretty established now, so we'll see more of it, I think. Okay. Next question. So a 27-year-old man with a history of AML underwent hematopoietic stem cell transplant 18 days ago. He now complains of abdominal distension and an 11-pound weight gain, right upper quadrant pain, and jaundice. His exam is remarkable for moderate right upper quadrant tenderness on palpation and abdominal distension with shifting dullness and a fluid wave. Liver function tests show AST 135, ALT 170, alk-phos of 120, bilirubin of 4.8, albumin 3.0, INR 1. Right upper quadrant ultrasound reveals significant ascites and an enlarged liver. Doppler studies showed normal flow in hepatic and portal veins. Which of the following is the most likely diagnosis in this patient? Acute cellular rejection, hepatosplenic candidiasis, sinusoidal obstruction syndrome, vanishing bile duct syndrome, or acute viral hepatitis? Options are acute cellular rejection, hepatosplenic candidiasis, sinusoidal obstruction syndrome, vanishing bile duct syndrome, or acute viral hepatitis. So we'll take a look at our answers here. 100%, excellent. So this is my topic, so I hope that means that everyone got it. This is a pretty, we can go back to the stem. You really, the only time hematopoietic stem cell transplant is going to show up on your GI boards is probably sinusoidal obstruction syndrome. So you really only have to read the first line and look at the history. They'll give you pretty much the whole consistent history of ascites, weight gain, jaundice. These are all diagnostic criteria for sinusoidal obstruction syndrome, which occurs in the first 2 to 3 weeks after a stem cell transplant due to the myeloablative therapy. There are other rare situations with other medications in patients who haven't gotten the stem cell transplant, but I think at least on the GI and liver boards, they've always given me a history of stem cell transplant. So that's the trigger here. And I think 100% of people answered correctly. So I think that's not, that's a good thing. You know, it's a hard thing to it's a hard entity to treat, well, and also recognize it's not always this clear cut on the, as on boards. In real life, there's so many other things that could be going on with these patients who've just gotten stem cell transplants, including, you know, some of these answer choices that involve infection, even maybe viral hepatitis, medication-related effects. But this is what we're gonna see on boards. The treatment, really, hematologists have been pretty good at, you know, choosing maybe a less toxic myeloablative regimen. And then in the peri-transplant phase, ursodiol seems to help. And then difibrotide sometimes comes up as a possible, it's FDA approved for treatment of this. So that is once you've made the diagnosis, and unfortunately, if you've developed SOS, difibrotide can be a treatment option. Usually on boards, they'll just have you like this, recognize the entity, not necessarily treat it. Okay, we'll move on. A 63-year-old man underwent deceased donor liver transplant 8 months ago for alcohol-induced cirrhosis. His liver enzymes normalized soon after transplant and remained normal. His liver enzymes have been repeatedly elevated over the past week with AST 180, ALT 212, alk phos of 188, normal total bilirubin, and normal INR. Tacrolimus level was most recently 2, and they tell you your target level is 5 to 7. He is feeling reasonably well, but does note some mild fatigue. He takes no other medications besides his tacrolimus. He takes no supplements. He is not drinking alcohol. Ultrasound with Doppler of the liver is normal. Serum CMV PCR is undetectable. You suspect acute cellular rejection given his low tacrolimus level. You obtain a liver biopsy. Which of the following features would be expected on his liver biopsy? Ductopenia and cholestasis, intranuclear inclusions with prominent mononuclear infiltrate, ductulitis and endotheliitis, or multinucleate hepatocytes. Go back to the all right. So let's take a look at our answers here. All right. Oh, this is quite a mix, so this is a good one to go over. So finally, Tammy, I think you're up.
I mean, I didn't do a good job explaining it on my section.
No.
Or we just haven't gotten to that yet. This is a great question, because it basically, you can get the whole history from the vignette, which is nice and really kind of helps it, kind of show where you should be leaning towards. And so basically you can get everything from the history. I think the key things here is not that it's not asking us what do we need to do to make the diagnosis. That's obviously you're doing the liver biopsy, but what are we expecting to find? And so I think the key things is to look at is the patient is asymptomatic, right? This is, and then what you also want to break it down into is kind of what we do with anyone who walks into your office with abnormal liver enzymes, or what is the source of that? And so you would do just like what you do to any patient. Are there any new medications? Are you taking your medications? Are there any supplements, any hepatotoxins? And it gives us all that information in there. And then when we also want to do looking at any kind of viral infections, right? It's giving us that information as well. And particularly when we're talking about liver transplant, we want to know the CMV, right? If that's, and they did check that for you. And then of course, the last thing we want to do is to make sure that you check the ultrasound and there's no anatomical abnormality. So it kind of gives you all this history. And so it looks like this man is also early after transplant. He's only been transplanted about 8 months ago. But we do see that he's what looks like he's under immunosuppressed. So this is really leading you to acute cellular rejection. And so when we have acute cellular rejection, we're going to see dactylitis and endotheliitis. I think it's a good thing that people did not get swayed by looking for findings of viral infection, right? And that is both B and D, the intranuclear inclusions and the multinucleated hepatocytes. You can see that in viral infections like CMV and HSV. But the key thing is kind of delineating between ductopenia and cholestasis and the dactylitis and endotheliitis. Those are more, C is a more acute reaction. And ductopenia and cholestasis is what you see with chronic rejection. So if you see someone who's, maybe more than just a few months out, maybe a year or even 2, if they're either off their immunosuppression or if they're chronically under immunosuppressed, which this man isn't at this point in time, then you're really going to have that bile duct loss and the development of cholestasis. So the answer is C, dactylitis and endotheliitis.
Cool. And you went over this, you've got this bonus slide.
Bonus slide. And so the treatment of acute cellular rejection is just, Solu-Medrol, increasing the immunosuppression, and sometimes even in severe cases, ATG. The bad thing about chronic rejection is that we don't really have good treatments for that. And I also did fail to mention, it's always good to realize, again, acute cellular rejection, someone's going to be asymptomatic, and all the liver enzymes can be elevated, right? It can be your ALK-Phos, your GGT, your AST, and your ALT. So it's not like one enzyme is more particularly elevated than another. Versus in your chronic rejection, you're going to probably see more of an ALK-Phos, GGT, and total bilirubin elevation, and that's just reflective of your, ductopenia.
Great, thank you. Okay. We'll move on. I think we're making good time, so we'll move to the next one. A 45-year-old man with chronic alcohol and hepatitis C, well-compensated cirrhosis, presents with a liver ultrasound report in hand that notes a 1.6 centimeter liver lesion in the left lobe of the liver. Which of the following is the next appropriate step? Repeat ultrasound in 6 months to assess for growth, refer to liver transplantation, obtain a triphasic CT, obtain a liver biopsy, or refer for surgical resection. This is a 1.6 centimeter liver lesion, compensated cirrhosis. All right. We can, it's a short stem. Yeah, we can look at the answers here. Oh, okay. Jump to responses. All right, Renu, this is yours, our HCC expert. Renu, are you? Yes. Oh, you're muted, I think, still. There we go.
Yeah, there you go. Thank you. Looks like there is some people have chosen A, so that's good, so that we can discuss. So this is a question on diagnosis of liver lesions. So this is a patient who has a 1.6 centimeter liver lesion on ultrasound. I think what is important to realize is that the patient has cirrhosis, and in all patients with cirrhosis, all liver lesions should be suspected for HCC until proven otherwise. So now we are worried about a liver cancer lesion here. So if I like to go through the process of elimination when I look at my choices, which I think pretty much everyone here has done. Without knowing the diagnosis of the lesion, we are not going to refer for treatment. So transplantation and resection will not be the right choice. So now you're left with either a biopsy, a CT scan, or a repeat and ultrasound. So I'll just go by elimination. So liver biopsy can be useful in HCC in specific rare circumstances where all other imaging modalities do not lead to the diagnosis and there are indeterminate lesions. But in general, we avoid it because, first of all, the diagnosis can be made on other triphasic imaging modality, which I'll discuss next. And second, there are some small risk associated with liver biopsy, like either bleeding from a biopsy site or even more dreaded complication would be seeding of the cancer through the needle track, which can then lead to cancer recurrence after treatment. So we try to avoid biopsy whenever we can. The remaining two options are either repeating an ultrasound or ordering a triphasic CT. For a lesion that is greater than 1 centimeter in size, either a triphasic CT or a triphasic MRI are really good at helping us arrive at a definitive diagnosis. So since this lesion is 1.6 centimeters, we don't have to wait and repeat an ultrasound. We can go for a more definitive diagnostic test here. So that will lead us to the triphasic CT. And if you think about why triphasic CT, because if they have another option of, say, non-contrast CT, you want to make sure that you're choosing a tri or a quad-phased cross-sectional imaging, because the diagnostic criteria are based on these enhancement patterns. And to make a diagnosis of HCC, you need to have enhancement on the arterial phase and washout on the delayed phase. And depending on the size, you would also need the presence of a pseudocapsule. So whenever you have these questions which are coming at diagnosing HCC, remember the imaging can make the diagnosis without a need for biopsy, but you do need the triphasic CT or MRI, and you need to have those classic imaging characteristics. That's what the question is testing. Yeah.
All right, thank you. We're gonna revisit this guy with the 1.6 centimeter lesion in a little bit. So I think we're gonna move to a different topic here. Now, this is a long stem. 60-year-old man, deceased donor liver transplant 2 months ago for hepatitis C, presents for urgent clinical evaluation. His hepatitis C was treated and cured pre-transplant. His immediate post-liver transplant course was uneventful. He received 4 doses of anti-thymocyte globulin induction. His liver enzymes and liver function normalized soon post-transplant as anticipated. He presents now with a 3-day history of fevers, persistent diarrhea, and a maculopapular rash on his chest, back, hands, arms, and legs. His current medications include tacrolimus and mycophenolate mofetil for immunosuppression. He also takes sulfamethoxazole, trimethoprim, because we're not allowed to do brand names, valganciclovir, and fluconazole for routine infection prophylaxis post-liver transplant. He states he is feeling very poorly and he appears clinically unwell on exam with a blood pressure of 93/58. Lab data reveals AST 19, ALT 22, alkaline phosphatase of 101, total bilirubin 0.7, albumin 3.6, and INR 0.9. Tacrolimus level is 7, which appears to be within your target. And he has developed new leukopenia and anemia with a white blood cell count of 1 and hematocrit of 19. What is the most likely diagnosis? Acute cellular rejection, CMV infection, small for size syndrome, or graft versus host disease. Let's go back again here. Long stem. So we've got acute cellular rejection, CMV, small for size, or graft versus host disease. So let's take a look at the answers. Got a few responses. Oh, 50-50. Good. It's a transplant question, so this is for you, Tammy.
Okay, thanks.
So I'm just going to say I thought this question was a little bit big for the GI boards. I think that this would even be, a surprise on the transplant boards. But we'll just go through it. So we'll go through the things that it looks like, and this is kind of bouncing off the previous question. What are the things we're looking for in the history, right? They give us a very extensive history. The key thing, it looks like it's not as Hep C because he was already treated before transplant. So let's just look at the answers and say what it isn't, and then we can talk about what it is and why. So you have normal liver enzymes. That's a key marker here. So we would say, and he's therapeutic as far as his TACRO level. So we're going to say no on the acute cellular rejection. We do note that he is leukopenic and has a low hematocrit as well. So we can see that in CMV infection as well. But this gentleman also is on his bowel site, right? So he is on appropriate prophylaxis. So again, very unlikely. As far as small for size syndrome, you're really going to see problems of delayed graft function, actually. You might see some elevated bilirubin, but you're also going to still have problems with like ascites and volume management, because again, it's just this liver that was maybe too small for the patient it was going into, so it takes a while to regenerate. So really that's an unlikely one. So we're left with graft versus host disease, which is very rare in liver transplant. Its estimated incidence is 0.5 to 2%. So it's very rare. However, it has a very high mortality. So it's very important to make the diagnosis. It can present in the first 1 to 8 weeks after transplant. And this is kind of where we see our patient is. And the key things is the presentation of the maculopapular rash, which, you could say, oh, is it a drug reaction, right? And everybody always likes to blame Bactrim. But he also has the diarrhea and the fever. So that really is really swaying us to GVHD. So again, looking at the history, your key things are going to be, that's the only thing that's going to give you the maculopapular rash, diarrhea, fevers this early after transplant, when everything else is, going well and he's on all his appropriate medications. Does that make sense?
Yes. Thanks, Tammy.
Still an unfair question, but just look for maculopapular rash.
Yeah. All right. So we've got a couple more. Oh, these keep going. A few more. We'll still be on time. A 38-year-old G2P1 female with a past medical history of obesity, dyslipidemia, and hypertension, and non-alcoholic fatty liver disease presents with right upper quadrant pain, nausea, and vomiting at 33 weeks gestation. Ultrasound shows cholelithiasis without gallbladder wall thickening or pericholecystic fluid. CBD is dilated to 7 millimeters with a suspected stone in the distal duct. Lab show AST 40, ALT 35, total bilirubin 1.8, alkaline phosphatase 210. Which of the following is the next best step in management? Start ursodeoxycholic acid at 10 to 15 mg per kg, ERCP, open cholecystectomy, supportive care, laparoscopic cholecystectomy. She is 33 weeks gestation with a suspected stone in the distal duct. Let's look at our answers here. Okay. Oh, little bit of a mix here. So deep D, this is a pregnancy question.
Yeah, great, thanks. So yeah, a little bit of two different choices. Mainly everybody chose ERCP, some people chose supportive care. So like Allison said, this is a question that's getting at choledocholithiasis in a pregnant woman and what the best management strategy is here. We know that gallstones are common in pregnant women. By the end of the pregnancy, up to 8 to 10% of patients will have gallstone formation, and that's due to increased cholesterol saturation of the bile, increased lithogenicity of the bile, and impaired motility and gallbladder emptying due to the changes in hormones. That being said, ERCP is considered to be a safe procedure, and it is the modality of choice to treat choledocholithiasis. So if you go back to the answer choices, they give you cholecystectomy as possible answer or ERCP. And I think between these two, for choledocholithiasis, ERCP would be the preferred management strategy, as there's no evidence of cholecystitis here. And then the question becomes, is ERCP safe in pregnancy, or do you manage more conservatively with supportive care or starting ursodeoxycholic acid? And the answer here is that ERCP is safe in pregnancy. There are certain things that you have to be careful with in terms of shielding. And ideally, if you have the ability to hold off on an ERCP in the first trimester or in the third trimester, it's better, because there's an increased risk of miscarriage earlier on and an increased risk of preterm labor later on in the pregnancy. So the second trimester is your sweet spot. But if an ERCP needs to be done, it can be done safely by reducing the fluoroscopic time, appropriate shielding and positioning of the patient. So therefore, ERCP is the right answer here. Supportive care is not the right answer. And ursodeoxycholic acid, although it may decrease the stone size and dissolve the stones, that takes months, and she has a stone stuck now, and she's symptomatic. So ERCP would be the right answer.
Oh, thanks. And I think you've got another slide here.
Yeah, and I think I kind of went through this.
Yeah.
Again, there's so many changes, hormonal changes in pregnancy that increase your risk for developing gallstones, increased cholesterol saturation, impaired gallbladder emptying. So the rate of gallstone formation goes up throughout the course of pregnancy, but complications related to gallstones remains low. So if it's just biliary colic, you might consider supportive care, but if you've got evidence of a stone obstructing, then ERCP would be the choice. Lap cholecystectomy is also considered to be safe in pregnancy, ideally in the second trimester.
Great, thank you. All right, moving right along here. We're back to liver lesion. So best approach to management of a patient with cirrhosis, child A, normal bilirubin, no varices on EGD, who has a 1.9 centimeter hepatoma on the edge of the right lobe. Oh, then we've got the STEM and the answers on this. This is nice when this happens. So you've got best approach to management, liver transplantation, tumor resection, repeat study in 6 months, transcatheter arterial chemoembolization, or radiofrequency ablation. All right. So I've been waiting for one more response. Okay, we can move. We can look at the responses. Oh, we've got a couple more. All right. It's the worst when they're 1.9 centimeters. Okay, Renu, you're up.
Yeah, hi. So I see that in this study, in this question, no one chose repeat study in 6 months. That's great. It's the easiest elimination, because in the STEM, they already told you that it is a diagnosed hepatoma. So once you've diagnosed HCC, we are going to now take action and not be waiting. So now we have 4 treatment options here: transplantation, resection, TACE, and ablation. I would look at first staging the patient to then decide which treatment is optimal. So this patient has a single tumor that's lesser than 2 centimeters. So he has early stage HCC or very early HCC. So I would definitely go for a curative therapeutic option. So then at that point, I would eliminate TACE. TACE is considered to prolong or to bridge to different therapies, but not considered curative by itself. So now you have two surgical options, transplantation, resection, or ablation. So I would think about whether this patient needs a transplantation, and the information they're giving us is he's cirrhosis, but he's Child-Pugh class A, so well compensated. They don't mention that the patient has any decompensating events. They do make a point to say that there are no varices on EGD. So this patient potentially does not need a transplantation. They haven't mentioned a MELD score, but given the information here, it's likely to be less than 15. So then we are looking at two other options, resection and ablation. Both can be considered curative for small lesions. There are no head-to-head large randomized control trials comparing the two for small lesions. But in different meta-analysis and studies, they have found them to be equivalent. And in these cases, I consider the location and of course, patient preference as big factors in making the decision. And they do give us something about the location here. They talk about how it's in the edge of the right lobe. When the tumor is on the edge, there are two factors here. One is usually these are easier to resect since they are in the edge. They should probably be able to remove a small area of the liver. And for ablation, lesions that are closer to the surface of the capsule of the liver or lesions closer to large vessels are more difficult and challenging to ablate, because when they're close to big vessels, you can have the heat sink effect where the heat you're now delivering through the ablation can be dissipated via the flowing blood. And so these lesions close to blood vessels, you might not get the whole lesion. And then the lesions on the edge or close to the capsule, you don't have enough of a area through which your ablation needle can first traverse before hitting the lesion. So you're going to straight away hit the lesion. You can either potentially not get the entire lesion or cause complications due to rupture. So, so in this well-compensated patient who has a single early lesion, resection would have pretty high chances of curing the patient of the tumor. So the resection would be the right option here. If the stem, and I presume in general, the stem will be longer in most of the board questions, probably give you more information about the cirrhosis for you to make a decision between transplantation and resection. I think they've given you 1.9 centimeters because you need to be 2 centimeters to meet Milan criteria for liver transplantation. So a patient like this will face the option of either undergoing a resection now, especially if he's well compensated, that will be a good option, versus waiting for a few months while we monitor this lesion, which is what we have to do if the patient was decompensated. And in those cases, there is always risk of hyperprogression or rapid progression during that waiting time. So if all else being equal, if the patient's well compensated and is able to undergo surgery, this would be a very reasonable option here. So the right answer should be B, tumor resection.
Great, thank you. Thank you. All right, we'll move along. Yeah, so 66-year-old woman with a history of heart failure has been complaining with abdominal discomfort. The ultrasound of liver shows a nodular liver. Portal pressure measurements show a hepatic venous gradient of 10. Which of the following is the next best step? Perform an EGD, begin a transplant evaluation, refer to cardiology to improve cardiac function, start a non-selective beta blocker, or start a PPI. So we got a heart failure, nodular liver, gradient of 10, and your options: EGD, transplant, refer to cardiology, beta blocker, or PPI. So look at let's look at our options here. Yep, got a few responses. 50-50. Okay, that's good. It's always nice that there's something to debate. So Amanda, this is yours.
All right. So pretty short question stem, but basically you have a lady who has heart failure, and then they have what appears to be, what is portal hypertension, which is the pressure gradient of 10. So just as a reminder that the definition of portal hypertension is a gradient greater than 5 millimeters of mercury. So the little bit about heart failure that was thrown in a question stem, I think to throw people off, is because heart failure can also cause portal hypertension. And so they wanted to see if you could be swayed by that to simply send it off to cardiology. So one important note is, and Allison, can you go to the next slide real quick? Yeah, is that in patients who have heart failure, even though they can have portal hypertension, the hepatic venous pressure gradient is typically normal, which is the case in patients who have a post-hepatic cause of portal hypertension, which is essentially right heart failure, pulmonary hypertension. So in this particular patient, because they do have a pressure gradient, then you're looking more at the other causes, such as, for instance, cirrhosis. So perhaps in this patient, the heart failure led to cirrhosis. So the appropriate answer for this patient is to actually perform an AGD for variceal screening. Not enough information in the question stem to warrant a transplant evaluation, and perhaps you'll use a non-selective beta blocker in the future if you do find varices, but it's not the best first choice for this particular question.
Great, thank you. I like this slide. I'm going to steal it from my talk next week, next year. Okay, we move. Okay. So the next question, 50-year-old woman, history of hepatitis C cirrhosis, presents to the ED with a complaint of 2 days of right upper quadrant pain. She has no history of ascites, but has grade 2 varices on EGD 1 year ago, currently being treated with Nadolol. Her vital signs, pulse of 67, blood pressure 125/70, respiratory rate of 14, O2 set 98%. Her exam was remarkable for moderate right upper quadrant tenderness on palpation. Her white count is 11, hemoglobin 11.1, platelets 102, AST 95, ALT 130, alkalis 102, total bilirubin 1.2, albumin 2.9, INR 1.3. Right upper quadrant ultrasound revealed normal gallbladder, CPD 3 millimeters, liver small size, nodular contour, no liver masses. Doppler study showed normal flow in the hepatic veins and a thrombus in the main portal vein with no evidence of collateralization and no arterial pulsations within the clot. And the serum AFP level is normal. Okay. Oh, this one is a little, we'll go through this quickly. What is the best next step in the management of this patient? Begin therapy with a NOAC, perform ligation of her varices, then anticoagulate, continue to observe her or recheck a Doppler study in 3 months, refer her for urgent liver transplant, or begin DAA therapy for her hepatitis C infection. All right, so we've got a few options. Looks like a thrombus in the main portal vein, and our options are begin a NOAC, ligate her varices, then anticoagulate, observe and recheck a Doppler study, refer for transplant, or treat her hepatitis C. Okay, we'll go to the answer choices. Okay, sure. 100%. So Amanda, we can do this one, the board answer quickly.
So just a real quick note about portal vein thrombus is that it's pretty common in patients with cirrhosis. So even when the INR level may be quite high, because they can also have a protein C and S deficiency, which are anticoagulants. So in these patients, they might actually be hypercoagulable. So anyhow, the question stem tells us that this patient has a portal vein thrombus. And the studies have shown that using systemic anticoagulation can be helpful in leading to recanalization, and also just improved outcomes when you use anticoagulation. So for the purpose of this question stem, the answer is B, as everyone chose, to perform ligation of varices and anticoagulate. just to point out that the New York guidelines does say that for a patient who needs primary prophylaxis, that the recommendation is actually to start them on a beta blocker and then ban them only if they are intolerant or contraindicated to a beta blocker. And I think that's partly just to not delay the initiation of anticoagulation.
Okay, good. Well, everyone got the board answer to this correct. So great. I think the other ones, NOAC, there's no data for, and the others might be right, but that they want you to ligate first here. Okay, we'll move to the next one. We've just got a couple more. So 56-year-old woman with autoimmune hepatitis, related cirrhosis, history of hepatic encephalopathy and ascites. She is brought to the emergency department by her daughter for being sluggish for the past few days. Her daughter increased lactulose frequency, but the patient did not improve despite having had 10 bowel movements a day for 2 days. Her medications include spironolactone, furosemide, and lactulose. On exam, her vitals are stable and she is alert and oriented to place in person without asterixis. What is the next best step in management of this patient? Admit her for more testing to rule out electrolyte abnormalities and infection, add rifaximin and zinc, obtain MRI of brain, obtain blood ammonia levels, refer for psychometric testing. All right, look at our answer choices here. We got quite a few. Oh, 100% again. That's great. Okay, Amanda, this will be quick then.
So everyone knows it already. Just to review real quick, the most common cause of HE is almost always actually medication noncompliance. But in this particular patient, she's already taking enough lactulose and having more than enough bowel movements. So the investigation should be on other causes of hepatic encephalopathy. So that can be anything from infection, dehydration, electrolyte disturbances, GI bleeding, a neurologic event like a stroke, toxins like alcohol or any other medication. So those are all the things you want to look for, which are all included in answer A. Just a quick note, we don't use ammonia levels for diagnosis or management in these patients. And although brain imaging may be helpful in this particular patient with a normal exam, we would probably opt for A before we would go to any type of brain imaging.
Okay, great. All right. Here we go. Here's our guy with the 1.6 centimeter lesion who came back. So 45-year-old man, chronic alcohol hep C, well compensated cirrhosis, presents with liver ultrasound report in hand that notes a 1.6 centimeter liver lesion in the left lobe of the liver. The patient now returns to discuss the results of a triphasic liver CT that you ordered. Now the lesion measures 2.7 centimeters and enhances on arterial phase and washes out on delayed images, and a rim of capsule is visible around the tumor. What is the next best step in management? Measure serum AFP, refer for tumor biopsy, refer for liver transplantation, refer for surgical resection, or refer for ablative therapy and liver transplant evaluation. I wonder how long it took him to get the CT. All right, that's 2.7 centimeters. We'll take a look at the responses. Oh, there's a mix again, these cancer questions. Okay, that's good. It'll be good to discuss. So Renu.
Yeah. Yeah, I like it when it's mixed. So in this patient, so it's the same patient who had 1.6 centimeters, and now the triphasic CT is showing 2.7. To briefly discuss that point, in general, the tumor doubling time for HCC is around 6 months, which is why we opt for imaging these patients every 6 months. Of course, there is variation, and there are slow and rapid progressors. So it is possible that he had a more aggressive HCC, which has been growing faster than median. It is also possible that the imaging, the ultrasound was not accurate in the size detection. So MRI or a CT scan are better at detecting some of the lesions, especially if the location is in the caudate or somewhere in the posterior parts of the liver. And if the liver is very fatty, or if the patient is obese, or if there are intervening gas bowel, there are different reasons why an ultrasound could have underestimated the size of the lesion. So I always, remind my patients not to compare apples and oranges, and not try to look at these different kinds of modalities and then wonder for these when there are a few millimeter differences. But what we have now is a lesion that is larger than 2 centimeters, and now it's meeting diagnostic criteria for HCC. It's arterially enhancing and washing out and greater than 2 centimeters. So we have a confirmed case of a patient with HCC, also has underlying cirrhosis. So you're right in ruling out the need for a tumor biopsy because the patient is meeting radiologic diagnostic criteria. Now, measure serum alpha fetoprotein. It's not a wrong answer. It will help in prognosis. It will help in tracking the lesion. But the question is, what is the next best step in the management? And I think once you have a diagnosis of HCC, like I mentioned before, you want to go ahead and try to secure a more definitive treatment plan, geared towards curing the disease. So if there are better options than measuring serum AFP, I would not choose that in this STEM. So that leads us to, I see that people eliminated resection. Happy to see that. Yes, it is a single lesion, potentially resectable, but the patient has portal hypertension. How do we know that? They mentioned here the platelet count of 85,000. So in general, we use a cutoff of 100,000, but we do look for multiple other, factors. We see if they have varices, do they have splenomegaly, intra-abdominal varices on imaging, and platelet count to assess the degree of portal hypertension. Because once you have portal hypertension, resection can be associated with high rate of complications and bleeding. So now you have a transplantation or a therapy along with referral for transplantation. And the correct answer here is refer for ablation and liver transplant evaluation. The reason is the process of liver transplant evaluation, getting the patient on the list and getting the patient eventually transplanted can take months to years, especially in different regions of the country. It's different, and especially in California, it's true. So the guidelines recommend offering bridging therapies to maintain the tumor burden within Milan criteria till the patient can be eligible for liver transplantation. So the right option would be to do both bridging loco-regional therapy while you refer and get them ready for liver transplantation. So there's a bonus slide here on transplantation for HCC. So in patients who have early stage HCC, BCLC class A, who have cirrhosis, and especially if they're decompensated, then transplantation is considered the best curative option for both their cirrhosis and their HCC. This can be associated with a 5-year survival upwards of 70%. Recurrence is still possible. Usually the recurrence rate is around 10%. We do screen for these possible recurrence post liver transplant. And I think in my talk, I do go over some of the criteria for who is considered transplant candidate based on size and number of lesions. I don't know, Allison, do you have to click again? I think it showed up.
Yes, I think one more click.
Yeah, so you don't have to remember these numbers. I think those might be more important for transplant boards. But in general, you could try to remember Milan criteria, which is single lesion less than 5 centimeters or up to 3 lesions. All lesions should be less than 3 centimeters. If you're within that size and number range, then you'll be considered eligible for transplant. We do have more expanded criteria where we can try to downsize the patient and then offer transplant. I'm pretty confident those will be outside the limits of the board. But Milan criteria is something simple and easy to remember. And that's the size when you're eligible for liver transplantation. Thank you.
You've got a question in the Q&A box for what is the about HCC surveillance after transplant. It's a little different setting, but what is the frequency of surveillance that we do for after transplant for HCC?
Yeah, that's a good question. And to be honest, it is not set in stone. The guidelines for pre-transplant or the guidelines for evaluation HCC surveillance in a cirrhotic, we do have international guidelines. Most societies recommend every 6 months. But post-transplant, we take an approach of risk stratification. We look at multiple factors which increase their risk for recurrence. For instance, we look at the explant. If there is microvascular invasion in the explant or extensive tumor burden in the explant, we know that they are at higher risk for recurrence. So those kinds of patients, we do more frequent HCC surveillance in the first 2 years. In my practice, depending on some of the criteria that I use, I survey them every 3 months in the first 2 years. And after that, for the high risk patients, after that, go every 6 months for another couple of years. The risk of recurrence is highest in the first 2 years. So that is when we have to decide whether it's every 3 months or 6 months. And we use a risk stratified approach for that. It's usually 3 to 6 months.
Thanks, Rania.
Thank you.
All right, we've got one more. Oh, this one. Okay, sure, we can do this. Which of the following is a risk factor for ischemic cholangiopathy? Primary biliary cholangitis, liver transplantation, Budd-Chiari syndrome, autoimmune hepatitis, or acetaminophen toxicity. Let's see, one more coming. Or we can move to the results here. Oh, there's no, there we go. Okay, I'll let you 100%. Wait, so Tammy, was this the question that you, I think I had a different version of the questions in the.
I have, I do too. There's like, I haven't seen this one and there was 2 other ones, but I'll make it quick and dirty. How's that? Is this the last one? Okay, I haven't seen this. I'm hoping, I agree with you, liver transplantation. When I think this harkens to one of the last slides on my talk about complications after liver transplant. And so if we have, for some reason, if we don't have adequate hepatic arterial supply, then we're going to get that ischemic cholangiopathy because the bile ducts are served solely from the hepatic artery flow. So we'll just kind of like put that there for the risk of ischemic cholangiopathy, right? None of these other ones are really going to cause that. And then there were 2 other questions that I thought that were helpful. One of them is, again, you will get a question on HPS. You'll have a patient who comes in with cirrhosis, portal hypertension, maybe they have a low MELD, 15 to 20, but they're hypoxic, okay? And so your differential is gonna be HPS or hepatopulmonary. I'm sorry, that's the same thing, hepatopulmonary or portopulmonary. Again, your difference, your portopulmonary hypertension is going to be an elevated RVSP on echocardiogram. For your HPS, they're going to ask you, how do you make that diagnosis? And you're going to make it with the cardiac echo with a bubble study showing left-sided bubbles, but after the 4th, anywhere from the 4th to 6th beat, okay? They may try to confuse you and say, oh, you had some immediate bubbles, but again, these are late bubbles. These are bubbles that are going through the pulmonary vascular system. They're not absorbed, so they're going back into the left side of the heart, if that makes sense. Okay, they're not going to try, they might say, oh, you get a CT scan. CT scan is not diagnostic, it's not specific. They're going to ask you HPS about late bubbles on echo. And then I think there was one last question too. It was like a super easy one. Let's see, hold on.
It's about contraindication.
Yeah, contraindication to transplant. That was like, there was a slide on that. So basically, contraindication for a liver transplant in this particular slide was hepatocellular carcinoma with macroscopic invasion of the hepatic vein, right? So that would be a reason if we have macroscopic invasion, that's considered metastatic in my book. So we're not going to make any big change. I mean, we're not going to be making life impacts in someone who has kind of metastatic liver cancer. So that is a contraindication. Just in review, remember HIV, we can transplant, we cannot transplant someone who has AIDS. And portopulmonary hypertension, if you have a mean PA pressure of greater than 35, we cannot transplant them. We can if we can get it less than 35. And again, an absolute contraindication to liver transplant is if someone has portal pulmonary hypertension with a mean PA pressure greater than 50. That's like kind of high risk of death on the table. Okay, so that was a little summary of the questions that didn't make it on.
Thanks, Tammy. All right, thanks everyone for sticking through the whole thing with us. And so we'll wrap up this session for today.
Yep, and we thank you to all the panelists. You did a great job, and we're so grateful for having you here today. We'll see everyone again tomorrow morning at 8 a.m. for lower GI and small bowel review. Okay. Thanks, everyone. Bye.